Good morning to the Indian faculties and viewers from the SAARC countries, and good evening to the international faculties. Greetings from Urological Society of India and Indian School of Urology. I take this opportunity to wish all of you and your family members a very happy and prosperous Diwali. Today we are having a webinar on one of a very common topic in the females, bladder outlet obstruction, which is quite underreported in our country, but it's not an uncommon problem. Today, we have Dr. Arun Chawla, the convener of this program. He has compiled an excellent, interesting academic program on this, and we have a good, eminent faculties, both from India and from US, and they will be elaborating on the various aspects of bladder outlet obstructions, and we have a very interesting case discussion also in the end, and an expert panel to discuss the various problems related to bladder outlet obstruction. So with this, I welcome you all again to this program on this auspicious day of Diwali in India. Now I would request the President of Urological Society of India, Professor Anand Kumar, to give his address. Over to you, sir.
Good morning to everybody, and maybe good evening or late night to my friends in US. And at this occasion, I would like to bring the greetings from Urology Society of India and very warm welcome to such an important webinar, and also take the opportunity to wish you a very happy Diwali. You can see the commitment of USI that even in such a important festival, we are keeping our commitment of learning and keeping the webinar alive. So that is the thanks to Dr. Rajiv TP and Dr. Arun Chawla to keeping us busy all the time. And this female bladder outlet obstruction, actually this is a very puzzling situation because it was not very well appreciated, and many experts denounced that such disease doesn't exist. And around 1988, 89 and 90, we saw a few patients, even the female, presenting with the renal failure and obstructions, upper tract changes, all the investigation done very extensively. And then we had a group of the patient, we did everything, all studies, and then we sent the paper in Journal of Urology, and that was accepted long back. And then we again published that how you can tackle it, how you can cut bladder neck with the female resector scopes. And we again published it now using the laser fibers with the and doing more precise bladder neck resection. Even female urethral stricture was also not very much appreciated, but we keep getting the patient strictures in the mid urethra or distal urethra, which requires some kind of urethroplasty. Even last week, we did one bladder neck resection and one mid urethral stricture with the vaginal flap. So this disease keeps on coming and troubling us. And then apart from that, many functional female urological conditions present in a similar way. So it's very important to understand them, do the proper investigation, which includes the video urodynamics and cystoscopy, free flow, and other make sure that they are not constipated. All those things are very important, and so that I hope this webinar will discuss all these important issues. We have a very eminent faculty, and I could see Professor Charles Powell, Dr. Singla, and I can't see Dr. Gopal Vadnali. Maybe he'll be joining soon. And so that we'll discuss all things, and it will help our members to understand better and treat our female patients well. And I also see there is another good sign that many female urologists also participating as experts, and this is a good sign that in India more and more female urologists are coming up, getting trained, and this is a very welcome sign, and we are very happy to see this growing sign, and we'll encourage more and more our female colleagues to come forward and take this specialty, which is very important specialty. At the same time, as a president, I would like to wish you a very good health in such a bad pandemic times, and everywhere it is coming back, and also that it looks like that vaccine is at the verge of coming up, but it will take time to be vaccinated and take time for this pandemic to go away. So be take care of yourself, take care of your loved one and your families, stay safe, and wish you a very good health and happy Diwali, and welcome back to Dr. Rajiv TP.
Thank you, sir, for your enlightening words. Now I would request the Chairman, Indian School of Urology, Professor Rajiv Sood, to say a few words. Over to you, sir.
Thank you, Dr. Rajiv TP, President USI, and all the eminent faculty, international faculty who have joined today's webinar. This is the festivity season. First of all, from Indian School of Urology, USI, I extend greetings to all the participants, delegates, members of urological societies and the urology community across the globe. Today's webinar is very important because in the development of subspecialty or cell-based functioning of USI, which we started 3 years back, female urology had been a major component, and it was always there, and many of the female urology experts who are there in India and who were guided by in the past by Dr. Frequent visits to India by Dr. Gopal Badlani, Dr. Ajay Singla, and today Charles Powell is also with us, and we are enriched, and we are expecting a great webinar today, and where all of us are exchanging their views, experiences, and also point of techniques in dealing with the physical and also functional obstructive pathologies of female urology. In our center, we have published several innovative female urethral operations, replacement surgeries, and also Dr. Gopal Badlani was instrumental when we developed through USI the guidelines for overactive bladder and dysfunction, various dysfunctions. In this series, in continuity, we wish all the best to today's webinar, which is very well crafted and also will pave way for all the urologists in general and female and reconstructive urologists in particular to get enriched in their knowledge and skills to enhance this subspecialty of urology. Again, all the best for the festivity season. Relax because of the COVID, as our president is repeatedly warning in all the webinars, and this COVID waves are coming again, and to deal with the urological patients, surgeries, and the atmosphere which is there in the hospital, it makes healthcare workers more susceptible to COVID. Be careful, be happy in this festivity, and all the best again for this great webinar today. Thank you.
Thank you, sir, for your kind words. Now I would request the convener of the program, Dr. Arun Chawla, who is the co-chairman of Indian School of Urology, to take over the proceedings. Over to you, Arun.
Good morning, everybody, and wishing you all a very happy Diwali weekend. And welcome to today's program on female bladder outlet obstruction. As we all know that true prevalence of bladder outlet obstruction in women is unknown, but can be up to 23% of the patients presenting with lower urinary tract symptoms. In men, model of bladder outer obstruction secondary to benign prostate enlargement is a highly prevalent condition with predictable outcomes after treatment. Such a condition doesn't exist in women. Voiding dynamics differ in both the sexes, and therefore the same nomogram and the values cannot be applied in both. Anatomical difference in women make them bladder by simply relaxing the pelvic floor or just by mild abdominal straining. So the mild increase in the pressure values and mild decrease in the flow rates, which may be insignificant in men, may be significant as a predictor of bladder outer obstruction in women. Again, the symptoms in women with bladder outer obstruction may be purely storage, just increased frequency and urgency on one hand, and on the other hand, maybe a retention urine with bilateral upper tract changes. So the suspicion is the key. When suspected, the diagnosis is usually by a combination of different investigations, which include flow rates, the pressure flow studies, and especially the video urodynamics. And we can direct the treatment by identifying the cause of bladder outlet obstruction, which can be anatomical, like because of ureterovaginal prolapse, the strictures, the post-anti-incontinence surgeries, the functional cause like dysfunctional voiding, the Fowler's, and the neurogenic causes. And the treatment should be directed towards the cause and to give the best results. After today's webinar, we aim to gain a knowledge and a correct perspective in identifying the sequence of investigation to follow in a woman with the LUTS suspected to be having a bladder outlet obstruction. We should be able to read the pressure flow studies in different scenarios of women with bladder outer obstruction. We aim to correctly plan the primary treatment as well as the alternative treatments for these patients with the aim to preserve good quality of life as well as the incontinence. With this, we'll begin with today's program. Little information to share. Dr. Gopal Balani may not be able to attend the last session of case scenarios because of personal issues. So he'll be making his first presentation with the anticipated approval of the chair and the experts. May I request Dr. Gopal Balani to share his presentation? Dr. Gopal? Over to you, sir.
Yes, thank you for allowing me to present first. I used my senior citizen status to ask Arun if I could present first. So I apologize for making the sequence a little off key for you all. But I'd like to share my thoughts on the female urethral diverticulum. A condition that is known to most of you, although not recognized easily in clinical status. So I'll start off with a presentation of a case. You have a 51-year-old G3P3 presenting with a anterovaginal mass with compression. It shows some purulent discharge. She also has complaints of dysuria and dyspareunia. Urodynamics shows stress leakage with Valsalva. MRI confirms a proximal urethral saddlebag diverticulum. So the question that I hope to answer today is, if she desires surgery, what is the best surgical option for her? Should we excise the urethral diverticulum, wait for a staged surgical management of the stress incontinence? Urethral diverticulum, to me, should be done at the same time as doing a fascial sling. Should we wait or do a synthetic sling simultaneously? And should we do a periurethral injectable therapy, or for the rare cases, a Spence procedure with fascial sling? I hope at the end of 10 minutes, we can arrive at an answer. The condition is a challenging one and diagnostically sometimes very subtle. and reconstructive problem can be an issue depending on the size and location. It presents with various clinical presentation. Today, new imaging techniques have greatly expanded our understanding, and you'll see the MRI sequences, which is kind of the standard today. The focus on operative reconstruction is to do it in such a manner that you preserve the urethral continuity and not cause any fistula formation, and also maintain as much support as possible. The reason for a diverticulum developing is typically due to a recurrent infection, most prominent in the distal 2/3 of the posterior lateral urethra, that is towards the vagina. The diverticulum can develop in the periurethral fascia, and typically there is a single ostia or a neck connecting it to the urethra. As you see in this diagram, there are the urethral lumen and the periurethral gland, the infection. Sometime occasionally, even the Skene's gland, which can get blocked, can back into a urethra and cause a urethral diverticulum. That's an uncommon cause. As far as anatomically, most commonly, it is either coming to one side or the other, and or surrounding in a horseshoe fashion, or rarely in a circumferential, almost circumferential fashion, which is a difficult one to deal with surgically. The prevalence is as much as you look for it. It can be subtle, but it's believed to be 1 to 6% and significant bothersome to a portion of them. The classic symptoms described are dysuria, dyspareunia, and post-void dribbling. The actual symptoms can be presenting as irritative LUTS, pain, infection, urethral pain or touch pain or pelvic pain. So a variety of presentation, including a vaginal mass, depending on the presence of stone and or rare malignancy. 20% of them are asymptomatic. It's written that its diagnosis is often delayed for several years before it's picked up. Physical exam still remains a very significant portion of the diagnosis. Being aware of it, an anterior vaginal mass that is gently stripped for purulence that appears at the meatus. Urinary tract infection, again, E. coli is the most common. The cystourethropy, which tries to visualize the ostium, is very difficult and rare to see this ostium unless purulence is extruding from it while you're doing a 0 degree or a flexible scope, unlikely to see with a 30-degree lens very often. Urodynamics is not mandatory, but most often 50% of the patients might have stress incontinence, so you might want to assess that at the same time. I think the positive pressure urethrography or double balloon technique is a thing of the history. Almost nobody does this anymore. A VCUG, once again, is rarely done. Today, most commonly, you're either doing an ultrasound, which you guys are much better at it than we are here. But MRI, since it's an expensive test, but it's the standard with which today we make a diagnosis of urethral diverticulum. And you can see in this nicely showing that it's a saddlebag or virtually all around the urethra, and seen in a sagittal or a coronal section, you can exercise it. The surgical principle of repair is with any reconstructive surgery, you need to have a well-mobilized vascularized flap. You need to take down the anterior vagina and remove the entire diverticulum. And in a pictorial fashion, you look at the U-shaped incision, that's typical. After you take down the flap, the diverticulum is here. Typically, you make a transverse incision to separate out a second layer, which is the pubocercal fascia. Try and go more lateral than the urethral diverticulum because it helps you in your repair, because very often this is very tenuous and breaks down. And if you start more lateral, it's easier in terms of doing the dissection. You can dissect upwards and downwards. If it's a very proximal urethral diverticulum, you need to be careful if it's abridging the bladder neck. Once the ostium is identified, it's never as clear as this picture. You tend to excise. It's okay to open the urethral diverticulum if you have a a horseshoe or a saddle shoe to get to the lateral ends of it, which makes it easier. And then you identify the opening, which sometimes you need to inject a gel with methylene blue through the paracatheter through the meatus to identify it more easier. And then you repair it. The defect should be smaller than what it is in this diagram. And then you repair it in 3 layers crossing. So one is a vertical repair here, and then you have a transverse with the pubocervical fascia, and then the flap goes up there to close it. That's only doing the diverticulectomy. Associated surgeries can be pubovaginal sling at the same time, using a Marquez flap, typically if you're doing the repair with a sling. Postoperative management need to leave the catheter for a few weeks. If anticholinergics might be helpful in preventing spasms, whether you do an X-ray to confirm it's healed, and then you remove it. And generally need to wait 6 weeks to 3 months to establish the persistent voiding dysfunction and or incontinence that's present to deal with it. So the question then comes, sling or not to sling when surgically treating urethral diverticulectomy? It should be a shared decision-making with the patient. The expectation of the patients are important. Concomitant sling can only be autologous. You cannot put a synthetic sling in an infection state. It adds significantly to the morbidity of the procedure because you have to make an additional incision. All the dissection for the sling should be done before you start closing the urethral diverticulum, because otherwise your sutures might pull, etc. So all this should be done if you're going to do a sling. You must also decide whether you're going to do a Marquez flap between the sling and your repair. Delayed management is the current standard. You repair and wait to see if stress incontinence is bothersome and still present, and then 3 months later, you can do a mid-urethral mesh sling if it's okay with the patient and they consent to use of the mesh sling. In general, the postoperative complications, one of the most dreaded one is a urethrovaginal fistula. And depending on where the fistula is, the symptoms may be present with a continuous leakage if it's proximal to the sphincter. If it's distal, you can have a split stream, etc. The Spence procedure is often limited to very distal urethral diverticulum and sometimes very useful in pregnant women when they present with an acute and tenuous urethral diverticulum. So one other question that is often asked in the board exam, which is the best test for diagnosing? And the answer here would be an MRI is the most accurate diagnosis. What is the most commonest cancer found in the urethral diverticulum? The answer is an adenocarcinoma. Although the urethral malignancy more common is squamous cell carcinoma, the adenocarcinoma is more common in a urethral diverticulum in terms of the inflammatory response. So I thank you for listening to me. This is one of our cases, which was quite a difficult presentation, more anterior than posterior, and we went suprameatal. That's another approach in terms of trying to achieve this dissection and concluding that. Thank you very much for listening to me.
Thank you, Dr. Badlani. So now we move on to the session 1, which is original on the program. I invite Dr. Shirish Shande and Dr. Shailesh Rana to start this session. Over to you, Dr. Shirish and Dr. Shailesh.
Hi, good morning, and thank you for inviting me, USI and ISU, the School of Urology. Gopal, it was a pleasure seeing you and a happy Diwali. Ajay, a very happy Diwali. Charles, hi. Ajit. I don't see Shirish around, but then I think he should be joining any moment. But I don't want to delay the session. So can I start off by saying that the first scientific session is on urodynamics and evaluation of female with voiding LUTs Other Than Urodynamics by Dr. Amita Jain. Dr. Amita Jain is a gynecologist and a urogynecologist at the Vedanta Hospital in Delhi. And may I request her to speak for 10 minutes? We'll give expert comments later. And then I'll speak about the topic that she has just spoken about. Dr. Amita Jain, please. Is she here?
Yes, I'm here, sir. I would be allowed to share my screen?
Yes, please. Please do.
So are you able to see my screen?
Welcome and evaluation of females with voiding LUTs.
So
please speak for 10 minutes and then we'll have comments and questions later. Thank you.
I hope you are able to see my slides, sir.
Yeah, perfect.
Okay. So thank you very much, sir, Dr. Chawla and USI for giving me the opportunity to speak in this webinar among stalwarts of female urology. So I'm going to talk about the evaluation part. So the presentation would be failure to empty, that is urinary retention. As you can see that there are so many epidemiological studies which are showing very discrepancy because the accurate definition and appropriate diagnosis of these conditions are still not known. Though we know that it's not uncommon problem in women. And the situation is more complicated once it is presenting with other kinds of voiding dysfunctions, then the presentation won't be straightforward. This is the classification I've taken from Campbell, and you can see that today we are going to just concentrate over the voiding problem, that is failure to empty. And again, it could be because of the bladder, because of the outer, there could be combination as well. So the thing is that if we talk about separately about bladder outlet obstruction, most of these conditions, that is structural lesions, mechanical obstructions, can be easily ruled out by just history examination and few initial investigations. We don't need urodynamic study for these. Yes, we need urodynamic studies once we are dealing with these disorders, that is functional one. If there would be a kind of history of neurological disorder, then we can think about this part. But this is the part, that functional disorder, that is bladder neck obstruction, dysfunctional voiding, and Fowler syndrome, where we have to be very careful to make our diagnosis, and we need a good urodynamic investigation to differentiate it from the detrusor underactivity, that is problem with the bladder. As you all know, there is a basic difference between the voiding of men and women. Women primarily void by relaxing their pelvic floor. They don't need a very strong bladder contraction to void, unlike male, because of the long urethra, they need a very good bladder contraction. So that's why the voiding dysfunctions also differ. The bladder neck obstruction, you can mark the definition that, yes, you can diagnose that there is a problem with the bladder neck once there is no other cause for the obstruction and there is no increased striatal sphincter activity. While if it is present, then probably it's a dysfunctional voiding if a patient is neurologically normal. I know that this Fowler syndrome is going to be taken by the next presenters. So I'm not just telling you that please don't jump on this diagnosis whenever you are seeing a young woman with voiding dysfunction, because it's a very, very particular diagnosis, and you need a very good urodynamic study, because MUCP which should be very high, the UPP should be pulsatile. Why? Because it is a kind of channelopathy, and it could be hormonally dependent, and patient might present with polycystic ovaries and other problems. Now, so the aim of evaluation should be to rule out any other condition which can mimic the obstructive lower tract dysfunction, but it could be something else, not the bladder outlet obstruction. And once bladder outlet obstruction is there, whether it is structural or functional. So the history, we have to start with the history. So in history, you have to see what is the onset of symptoms, triggering events, different degree of voiding difficulties, other kinds of lower tract symptoms, and presence of UTI. It could be typical voiding symptoms of hesitancy, slow or intermittent stream straining, or it could be storage symptoms as well. Presence of pain should also be ruled out, because sometimes this pain is just causing the pelvic floor spasm, and once the pain is not there, patient can relieve of the problem. Bowel dysfunction, the constipation as mentioned by Dr. Anand, yes, it should be ruled out, because the pelvis is a small space. One organ is loaded, then other organ cannot work, function adequately. Surgery, any kind of surgery or in the pelvis, particularly for the incontinence surgery, slings, prolapse surgeries, or any kind of surgeries can cause some kind of anatomical obstruction as well as some kind of neurological problems as well. Review of medication, this is very important. There is a whole list of medication. It could be medication for the treating overactive bladder or bronchodilators, even the tricyclic antidepressants usually given for the painful condition like bladder pain syndrome, the amitriptyline very commonly given, and it can also accentuate the problem of voiding dysfunction. So we should always carefully ask that whether any new medication was recently started. Any neurological symptoms, go for the neurological examination. Questionnaires can help, but yes, usually in research work. So whenever a patient is coming off detrusor underactivity, don't think that symptoms would be straightforward. Symptoms could be misleading. Patient might present with enuresis, stress incontinence, even the impaired sensation of the bladder fullness. Though the prevalence of this condition is very, very high, supposed to be 45% in elderly women. Same with dysfunctional voiding. The symptoms, the storage symptoms are higher than the voiding symptoms, and the most common is urinary frequency, followed by dysuria or urgent continence. Voiding diary can help you if it is maintained adequately for 3 to 7 days, because it can give you a very fair idea of the voiding pattern. As you can see here, this patient we asked to particularly do the CIC. At least you know that the incontinence she is having is not other than overflow incontinence. Now we have to differentiate between detrusor underactivity and bladder outlet obstruction. So coming to the next examination, yes, the urogynecological evaluation is most important, which should be done on the first visit of a patient to you. And also if there is any neurological signs or symptoms, a careful dermatome examination of patient should be done. But if you are not very well versed, then please send these patients to your neurological colleague, neurologist. Okay, so the external pelvic examination, just see for these things: excoriation, vulvitis. It can be because of the incontinence as well, and this can create pain as well to cause pelvic floor spasm. Especially postmenopausal women can present with severe trophic changes. It could be urethral coruncle, but it could be just a labial fusion because of the severe atrophy, and these patients are having vaginal pulling of urine and present very lately because initially they are asymptomatic. Same with the malignancy. Sometimes because of the stigma, they are not coming to you, but once they are voiding problems and it's fast growing tumor, so they can present like that as well. Prolapse, I know Dr. Raja Maheshwari is going to take the thing, but you have to see whether it's the apical or in posterior anterior compartment. It can compress urethra and can cause voiding dysfunction. Every mass which is coming out couldn't be prolapse. It could be urethral diverticulum, huge urethral diverticulum, or vaginal cyst. All these things could be asymptomatic, so they can present once they are large enough to compress the urethra. Like you can see this in this examination, that on pressing the pus is coming out of the urethra. It is a diagnostic examination finding of urethral diverticulum. Same here. Here you can see that once we are aspirating this cyst, because it is not coming from the bladder, it's a vaginal cyst. It is an epidermoid cyst and having a kind of straw-colored fluid inside it. So then you have to do internal examination. You have to see the pelvic floor tone as well as any tenderness. There could be trigger points or myofascial bands, or even you can see the antivaginal wall tenderness to see the painful conditions of the bladder. Staging of prolapse is important. You have to reduce the prolapse, and compartment-wise examination should be done, and bimanual examination to rule out any mass or retention of urine, that is full bladder. Then imaging, role of imaging, yes, you can see the bladder configuration, any diverticulum, bladder wall thickness, presence of high post-void residue, many things, but I am here concentrating on the thing which we usually urologists are not very well versed, that is translabial or transperineal ultrasound. You can give you can have this kind of inverted view of pelvic organs. Here you can see that whether the urethra is mobile or not. You can see the relative mobility of the bladder neck from that of pubic symphysis, and then you can diagnose the condition. You can see the bladder wall thickness as well. Here you can see this is the cystocele, and once you are doing asking patient to do Valsalva, the retrovesical angle is obtuse more than 180 degree, and also the lowest part of the cystocele is the bladder neck, so that's not obstructing one central cystocele, while here you can see that the angle is quite acute. Even at the Valsalva, it is increasing. So it's a lateral cystocele. The rugosity is maintained on examination. So in this way, you can see which cystocele is obstructing, which is not. Even a large mass from the posterior part can also obstruct the urethra, but you have to differentiate between anterocele and rectocele. Here you can see the continuity of the anorectal angle with this mass. That's mean it's a rectocele, but if it is not there, then it could be anterocele. You can see the inner side of content as well. As you can see here in this video, how it is compressing the urethra. Even after sling, you can see, you can just measure the distance between pubic symphysis and the sling. If it is less than 7 millimeter, it could be obstructing. As well as you can see the configuration. If it is not, see, it's quite acute. You can see the obstruction in translabial ultrasound. Though the dynamic MRI pelvis will give a better view of the thing, that here you can see the funneling of the urethra, as well as the cystourethrocoele, which is not obstructing. But here you can see the lowest part is of the cystocele is the bladder, not the bladder neck, so it can be obstructing. Same here, it is giving a more larger staging of cystocele. Here it is anterocele, which is obstructing the urethra. Here you can see, like, you can't make out what is coming out along with the uterus. So you can see in this dynamic picture that yes, it is the main rectocele which is coming out. The bladder is at its plate, but yeah, it's compressing the urethra. Same here, you can see it's the mainly it's the rectocele, nothing else which is coming out. Sometimes you can see other masses also causing the obstruction. Like here you can see this is a huge cervical fibroid which is causing compression on the bladder. And once patient is postponing her urination, she is having obstruction. This patient, you can see that there is a mass which is sitting over the bladder. It's giving the double problem, like it's not allowing bladder to fill, as well as there is a big rectocele which is also pushing the urethra. You can utilize other modalities as well as to see the upper tract changes like ultrasound or CT-KUB. Here you can see the bilateral hydronephrosis. Urethral diverticulum has already been covered by the previous speaker beautifully, that you can utilize these modalities to visualize the diverticulum. Now coming to the, this part would be covered by Dr. Nikhil Khattar. So I'm just going to touch the micturating cystourethrogram. Though the video urodynamics is better, but if the facility is not available, then it could also be a good option because it's cost effective, catheterless, less artifact, and lack. Though the problem is that you can't co-interpret. So you can see exactly what is the level of obstruction, whether it's a bladder neck, or it is the rhabdosphincter, the striated sphincter muscle, or it is the pelvic floor muscle where the obstruction is there. You can see if post sling voiding difficulty is there, then you can see exactly the position where the obstruction is there. As Dr. Gopal said that it's now obsolete, but yes, double balloon urethrography can be utilized in those places where MRI facilities, remote places where MRI facilities are not available. So you have to plug the one balloon to plug the bladder neck, and other one is to plug the external urethral opening, and then you can visualize the diverticulum. MCU can give you many pictures like the presence of a stone or diverticulum, the reflux, everything could be seen through MCU. The last thing, cystoscopy. For cystoscopy, you have to do a uroflowmetry at least. You can't jump on the cystoscopy straightforward. And
just a few seconds left, Amita.
I'm just, sir, closing. Just this is last slide. So urethral calibration has to be done, and once it is not good, then you have to do cystoscopy. This is my last slide, sir. So you can give see these kinds of picture. Urethral strictures could be there, and if you are just doing cystoscopy and dilatation under local anesthesia, you can create the false passage. There could be a stone sitting or some mass sitting at the bladder neck, and this could be the picture of the obstructive urethropathy. Like you can see the trabeculation or diverticulum as well. As you can see in this patient, this was a huge ovarian mass which was causing obstruction of the bladder. So hardly you can see the cavity here. So you have to utilize all these things. There could be some advanced investigation as well needed for very, very complex cases. So my take home message is that never jump on a diagnosis without thorough evaluation. Do a systemic approach, select and interpret investigation modalities carefully, and please never, never, never do cystoscopy and urethral dilatation under local anesthesia for these kinds of voiding dysfunctions. Thank you so much, sir.
Thank you, Amita. It's a great talk. You covered just about every aspect of the clinical examination and other evaluation rather than urodynamics. Now, can I invite Nikhil Khattar to speak on urodynamics and bladder outflow obstruction? And then we will have the comments after both the talks have been together. A rather difficult subject. Nikhil Khattar, please. Nikhil, are you around?
Yes, sir. Good morning. Good morning, everybody.
You have 10 minutes to make it as simple as you can. I know it's
yes, sir. Yes, sir. Yes, sir. So I'll start sharing my screen. Are you able to see the screen?
Yes, loud and clear. Nice and clear. Yeah.
Okay. So thank you, Dr. Arun and USI for
reconstructive urology at Medanta City in Delhi, and he's a very well acclaimed urogynecologist in this part of the world. Over to you, Nikhil.
Thank you, sir. Thank you so much. And thank you, USI and Dr. Arun for inviting me to give this talk. So I'll be presenting on urodynamic diagnosis of female bladder outlet obstruction. So I'll show you some of the traces in women, these three women who had voiding dysfunction. The first trace during the voiding phase shows intense generation of detrusor pressure with a pdet of Qmax of 95 for producing a very small flow of 2 ml per second. And generally, all of us would agree that this is bladder outlet obstruction on the basis of urodynamics. In the second trace, the pressure generated is 57, and still maybe many of us may still agree that this is obstruction. But in the last trace, the pressure generated is only 24. It's a weak pressure, and maybe most of us will not agree that this is an obstruction. So, how on urodynamics we will be able to give what are the cutoffs when we should say that this is obstruction, this is not obstruction, or this is underactivity, or what? Things for males, things have we have come to this level that we have bladder outlet obstruction index and contractility indices, because in males we had a prostate which was extensively studied, which could be deobstructed, and follow-up studies could be done to establish what actually makes urodynamic obstruction. But in women there was no such surrogate, and it was difficult. So research has gone uh, through different steps. And ideal urodynamic definition would be to know, when we say that female is obstructed, it should be that after deobstructing, she should be relieved of her symptoms. And the second thing is that whatever the diagnostic criteria are made should be applicable to both anatomical and functional causes of bladder outlet obstruction, as it is more difficult to diagnose functional causes of bladder outlet obstruction. So these are pressure and flow related definitions of female bladder outlet obstruction. These are the cutoffs that have been given over various years. The blue one is the pdet at Qmax. This is all during the voiding phase, pdet at Qmax, and this is the Qmax level. This is in 1988, the first definition that was given by Massey and Abrams, where a PDET of Qmax of 50 and a flow of 12 was said to be as obstructed. Later, Chasagne said that it is 20 and 15, and later 21, 11, 25, 12, like that. Uh, and later on, Kuo said it is 35 and 15. So there are a lot of definitions. We have to now pick what is actually right. When should we say that it is obstruction? Then the this radiological diagnosis is now considered the gold standard. This was described by Nitti, and it was after an observation in women with anti-incontinence surgery where they suspected obstruction, but on pressure flow criteria it was very difficult to diagnose that. So they said that any discrete area of narrowing, if it is visible on a micturating film, that should be considered as obstruction irrespective of the pressure generated. And then they deobstructed those females by doing a erythrolysis, and found very good results and relief of symptoms. And then they argued that similar problems can be difficult to diagnose cases may be present in women who have not undergone any uh, surgeries, any anti-incontinence surgery and functional obstructions. So if we again look at all those diagnoses, all those diagnostic criteria on the basis of pressure flow, then although the first one, that of 50 and 12, is a bit arbitrary and it was picked up, borrowed from the male uh, mm, diagnostic criteria at that time. Uh, the second one, this one was from clinical obvious obstruction, like post sling obstruction, or a stricture or a prolapse which was obviously pushing the urethra, and the criteria were then diagnosed. So they took obvious obstructions and did urodynamics on them to say that this is obstructed and these urodynamic criteria apply as obstruction. And then Nitti described his radiological criteria, and then those image-based definition is being used, has been used as a reference point for diagnosing pressure flow criteria in the rest of all the diagnosis. Why the cutoffs have gone from 20 to 30 now? Because now these recent studies have involved more and more of functional obstructions, and and that is why probably the cutoffs have gone slightly about 35 and 15. But we also know, and it has been studied, that urodynamic characteristics of anatomical and functional obstruction are similar. So whatever the criteria are developed can be applied to both anatomical and uh, anatomical and functional obstructions. This is unlike in men, where nomograms and definitions have mainly focused on men with prostate, and cannot be generally applied to functional obstructions, which are commoner in younger males. So a PDET of Qmax above 35 or 40 centimeter is definitely female bladder outlet obstruction, and below a level of 20 centimeter may or may not be excluded as obstruction, because many females who void just by abdominal by pelvic floor relaxation, a very little generation of pressure also may indicate obstruction. And there may also be coexistence of bladder outlet obstruction and underactivity, especially between 20 and 35 centimeter of PDET at Qmax. And in this gray zone, the radiographic evidence of obstruction becomes most important. So if all these three traces we do an MCU and see the voiding picture, in the first two we can see the area of dilatation and an area of narrowing. And lastly, in this also, where the pressure generated was only 24, again we see that there is an area of narrowing and there is a bulge, and this is an obstruction without doubt. In centers where video urodynamics is not available, and simultaneous tracing is not possible. Separate MCU and urodynamic studies can be done to arrive at a logical conclusion. Then these are only why only MCU may not be enough to diagnose obstruction will be evident with these two voiding films. You can see that the bladder neck is not opening here, and it is not opening here as well. But in the first trace, it is severe obstruction. It is bladder neck obstruction where she is generating a pDAT of Qmax of around 100. Whereas in the second, this lady is an underactive bladder. Then apart from this, there are nomograms also for diagnosing female bladder outlet obstruction, which have come up. The earliest nomogram was Blevas's nomogram, which used which is not being has not been used much because it overestimated obstruction. And the second nomogram which has come up recently is Solomon Greenwell nomogram, where a bladder outlet obstruction index for female has been described, uh, and there has not been any external validation of this as yet, but it appears promising. Right, that is all. We are also coming up. We have compiled a book also to declutter all this aspect. I, along with my colleagues, Dr. Rishi Nair and Dr. Arvind Panda, and if you allow, then I may introduce that book also. That will come up shortly in maybe January or so. Thank you so much.
Thank you, Nikhil. I think it was very well spoken. Basically, at the end of the day, the message is very clear. 15 years ago, when we started, you may call urogynecology, you may call it neurourology, but we started as a team of the pelvic floor. And this all boils down to that. We had Victor Netty come down to Bombay, then we had Gopal Padlani come down. And if you're looking at bladder outflow obstruction in females, then you have to get into neurourology, into pelvic floor, and into urogynecology. If there's an extrinsic obstruction, which is fair enough, you can have your MRIs, you can have your sonographies, but if you're looking into enteroseals and cystoseals and prolapse, then you require a dynamic MRI. If you're looking at bladder outflow obstruction without an extrinsic compression, then it's uroflow history. And I think video urodynamics and MCUG is the way to go. Without an extrinsic obstruction, you need to have video urodynamics to diagnose female bladder outflow obstruction. Clinical examination, very well spoken of by Amita. For functional obstruction, you do require to have a good understanding of neurourology. And I can assure you, we've picked up Cora Equinas after we've started the neurourology clinic. So in people interested in female bladder outflow obstructions, look at urogynecology, look at pelvic flow, look at neurourology. MRI is the way to go for extrinsic. Otherwise, video urodynamics is what can diagnose female bladder outflow obstruction. Thank you very much. I hope I made myself clear. I won't go further in because the speakers have been absolute fantastic. Thank you, Arun.
Thank you.
I'm
Thank
sorry
you, Dr.
my colleague Shirish could not join us, and I'm going to hang around to hear the whole webinar. Thank you.
Yes, sir.
Good morning, Charles, and hi.
Yeah,
Ajay.
before I wind up, there are questions from the chat section.
Yes.
One question to Dr. Amita and other to Nikhil. Dr. Amita, there's a question: what is the sensitivity and specificity on ultrasound regarding the slings?
Sir, I have read a lot of papers from Peter Ditz from Australia, and he has done a very good job. And he recommends it that sensitivity could be up to 93% and specificity up to the 100%. He says that if you are doing a pre-operative evaluation, you can see that whether the sling is too tight, and you can adjust at that time also. So it's quoted from his studies.
Dr. Nikhil, as a question to you, there's a lot of
Yes, sir.
information in the literature regarding the pDAT Qmax or we can use P det max in the female bladder outlet obstruction? Your views on that?
Yes, sir. This was first uh, described by the Blevas's cutoffs that were given, and they said that at times there are obstructions possible where even a trickle of urine is not seen and flow is not there, but a very high detrusor pressure is generated. So in their definition, they said any pressure generated more than 20, even without any flow, even with a zero flow, can be as obstruction. And they had also come up with a concept that when we do a simultaneous study and measure the parameters there, then because of the feeding tube, because of the tube there, tube-induced dysfunctional voiding occurs, and that can mislead it. So they said that a PDET max, that is maximum generated pressure, should be used rather than PDET at Qmax. Uh, and but it can be used, but it is not the norm now.
Okay. Thank you, Nikhil. Thank you, Dr. Shailesh Rana, for you are chairing the session as expert. Now we move to the session 2. I request Dr. Ajit Waze to start the proceedings. Dr. Nitin will not be able to join. I request Dr. Ajay Singla to join Dr. Ajit Waze as expert and as the chair. Over to you, sir. Dr. Waze.
Hi. Am I unmuted?
You're okay, sir?
Yeah, you're unmuted. Yeah.
Right. Good morning and wishing all of you a happy Diwali, especially Charles, a happy Thanksgiving, which is coming next week. And we are entering from what is known as a difficult problem to a really complex problem. When Fowler syndrome was first given in 1998 by Clara Powell, the origin of the Fowler syndrome probably is in 1998. And in BMJ, there was an article which was came from Clara, from Chris Chappell and Roger Kirby. He's saying the electrical activities, abnormalities in the urethra sphincter associated with the polycystic disease. Obviously, this is a very uncommon disease, very uncommon syndrome, usually occurs in younger people. There is no urological nor any neurological abnormalities found, including the MRI. However, it is a functional abnormality, and the only treatment which Dr. Charles Powell. Obviously, there is really hardly any need to introduce Charles Powell. He's an associate professor of urology from Indiana School of Medicine. Charles, we welcome you to join this webinar, and let us share some of the things. And then at the end, in question and answers, I'll ask you what are the new theories which are happening in the Claes syndrome. Ajay, you will be taking over as a co-chairperson, and you will be introducing Sanjay Sinha and the further part. So over to Charles. Welcome to India.
Thank you, Professor Ajit. That was very kind. It's an honor to be here. I'm going to try to share screen right now, and we'll be talking about the Fowler syndrome. Is everybody able to see my screen?
No? Yes.
Not yet? Okay. Is it visible now?
We can see the screen.
Very good. So I'm going to talk about the Fowler syndrome. I want to thank the, no, it's not moving. Hold on. I want to thank the organizers and especially Dr. Chalwa for the kind invitation to sit in front of such an experienced and well-known panel is really an honor. My objectives with this talk are to kind of provide a basic understanding of obstructed voiding in the female. That's been covered very well, including specifically female voiding dysfunction and Fowler syndrome. I want to provide some patient cases to kind of illustrate the points I want to make, and provide some papers that I hope will be landmark papers for others to reference later when we see these patients in clinic, as we all will. Key features of female voiding dysfunction are elevated post-void residual, straining, or pushing to urinate. These patients often have a lot of distress because of this. But as was mentioned before, sometimes these are asymptomatic, sometimes they're painful. And sometimes we see upper tract damage, association with UTIs, but seldom do these women have urinary incontinence with these obstructed problems. The differential includes Fowler syndrome, which is what I'm talking about, but also primary bladder neck obstruction. And it's difficult to talk about Fowler syndrome outside of that. I know Dr. Sinha will cover that in a few moments, but also dysfunctional voiding, of course, iatrogenic, a sling that's been placed too tight, neurogenic, pelvic organ prolapse, which was covered very nicely, constipation and medications such as opioids. But I'm going to focus on the first three because I believe the others are a little intuitive and easier to handle. But these I grouped together into three, almost one entity that you could really call dysfunctional voiding. There are certain features that make Fowler syndrome a little more favored, and certain features that make primary bladder neck obstruction more likely the diagnosis. So we'll talk about those as well. And then this is the last slide I'll have on primary bladder neck obstruction, but as was mentioned briefly earlier, a lack of funneling on video urodynamics often denotes primary bladder neck obstruction. There are a few hypotheses about what causes this. One is it's anatomical. There's fibrosis in the bladder neck. Ledbetter and Turner Warwick have really championed this. And more recently, Howard Goldman at Cleveland Clinic has hypothesized that this could be a functional problem. But either way, it's based in the bladder neck. Now, I've got a case I want to present to the panel and to the audience. A patient I saw just a few days ago in my clinic, 61-year-old female, straining to urinate, feelings of incomplete emptying, has complaints of recurrent urinary tract infection, is voiding frequently, it's bothersome, nocturia, very bothersome to her. No help with medication, and her post-void residual is very high at 400 cc's. She's had prior surgery, but she's never had a sling. She did not demonstrate any prolapse either. And so she started clean intermittent self-catheterization. She had some improvement in the nocturia, had a very nice bladder diary, but still was not satisfied with the symptoms. Underwent renal ultrasound, serum creatinine, these were normal. Ultimately underwent urodynamics, and in the urodynamics demonstrated a slightly elevated voiding pressure, 23 centimeters of water, a reasonable but low flow of 19 cc's per second, and an active EMG. Now, this active EMG worried me in particular because I believe that's one of the hallmarks of these women with the Fowler syndrome. And so the question becomes, how much is too much? And it was very nicely covered by Dr. Qatar about the Blavis-Grouts nomogram. That is a nomogram that I use in my practice. And so they really sought to answer the question, how much is too much? And to do that, they, of course, incorporated the flow, which has been done by others with regard to male voiding dysfunction. We've always taken a paradigm, this has to do with the prostate. And so we're familiar with these nomograms. And then the Blavis-Grouts nomogram, of course, applied the lessons we learned in male voiding dysfunction, largely because of the prostate. So really bladder outlet obstruction from a static organ, as Dr. Qatar noted, to the very dynamic female bladder outlet. And they did this by a scatter plot of the pressure at maximum flow plotted against the flow the free flow with a non-instrumented flow. And they found that there was a clear separation between these two groups of patients. And then, so they categorized women with obstruction ranging from mild to severe. And that was very helpful. Years later, as was also mentioned by Dr. Qatar, Solomon and Tamsin Greenwell in London developed a more simple approach using a mathematical formula to create a cutoff between obstructed voiding, and they also included radiographic data with their images to help determine, to help define what truly constitutes a pathologic or dangerous obstruction versus one that we don't worry about as much, or somebody who's not obstructed at all. And they looked at 535 women and used some of those women to create the data set and develop the rule, which was simply the pressure at maximum flow should not exceed 2 times the flow itself, the maximum flow itself. And this was very helpful. It's very simple. It can be done with very little thought, and you don't have to plot it on a nomogram. So applying these lessons to our 61-year-old female I mentioned earlier, she does have mild obstruction. She does have an active sphincter. I did believe this was Fowler syndrome, and I'll say why I'm saying did believe and not definitely Fowler syndrome in just a moment. I've offered pelvic floor muscle therapy, which she decided to start. We'll talk about the data for that shortly. Alpha blockers, vaginal diazepam, clean intermittent catheterization. These are all options. And sacral neuromodulation. Ultimately, if this woman does not succeed with pelvic floor muscle therapy, she has opted for pelvic floor muscle therapy. But shortly, I'll also talk about onabotulinum toxin used for this purpose in the urinary sphincter. So Fowler's syndrome, we're going to talk about a very simple definition for this. It involves elevated voiding pressures on urodynamic study, but we've talked about that already with lots of other entities as well. But the key to Fowler syndrome is it's the sphincter, not the bladder neck. So this is what distinguishes it from primary bladder neck obstruction. It's the sphincter itself. And of course, this is difficult to look at. This is a nice image, but we don't always get this on all of our patients. So hypertrophy of the urethral sphincter, Claire Fowler describes very characteristic electromyogram pattern, but this involves putting needles in the urinary sphincter. And I have a fear that if I start putting needles in all of my patients' urinary sphincters, they're not going to come back to see me. And so I'm never going to get to treat them. And so I don't do that. I apply the pads, the EMG pads, and against the anal sphincter, like probably most of us on this conference would do. And that I find to be sufficient, but there's a little bit of guesswork involved in that. So the symptoms, of course, typical patient, they have to be female, third decade, no evidence of a competing diagnosis. They have urinary retention in very large numbers, typically greater than 1,000 is not uncommon, but not necessary as part of the definition. No sense of urinary urge despite having very full bladders. Abdominal straining does not help this patient open or the bladder outlet and does not help the patient void. And a sensation of gripping the catheter when they do intermittent catheterization, often they have pain and difficulty getting the catheter to come in. I think this is very characteristic of the Fowler syndrome and very helpful in deciding who has Fowler syndrome versus dysfunctional voiding of an uncertain cause versus primary bladder neck obstruction. So the treatments for Fowler syndrome, I mentioned sacral neuromodulation, and that may be the option for this next patient. There is an excellent paper by Data and colleagues looking at 60 women with Fowler syndrome. This is the only paper that deals exclusively with Fowler syndrome for sacral neuromodulation. They're followed for 7 years. They had very good outcomes. 47 patients actually were voiding spontaneously at the average 7-year follow-up. So I think this is a very good option for these patients. A little newer to the field, and this is something that a lot of people are doing, but the data is still immature, is onabotulinum toxin in the sphincter. There's a pilot study dealing exclusively with Fowler syndrome patients. They follow these patients for 10 weeks with improvements in the IPSS, the Qmax, the post-void residual. And 4 of the 5 patients that started in total retention actually were able to void spontaneously. I have had mixed results personally in my own practice using onabotulinum toxin in the sphincter. But what I really believe works well and what there is very solid data for is pelvic floor therapy. And I want to refer everybody to a randomized controlled trial by Minardi and colleagues that appeared 10 years ago in the journal Urology. And they grouped these patients into three biofeedback groups plus a control group that didn't get any therapy, and they all got different types of biofeedback and different types of evaluation and pelvic floor therapy, and they evaluated these patients with the AUA symptom index score broken down into storage predominant scores and emptying predominant scores, and found that everybody who got the therapy had a significant improvement at 12 months. And so I think pelvic floor therapy is always a good first-line option for these patients. Vaginal diazepam is very popular, and at every meeting somebody talks about vaginal diazepam, but there is actually, and I use it myself by way of full disclosure for my patients, but there is actually poor data for its efficacy. It has been used, there are 2 randomized controlled trials using 10 milligram dose. Both have been negative trials. But there are some positive trials, but these are not on par with the 2 trials I mentioned previously. They're not placebo controlled. They or retrospective chart reviews, but they do show some evidence for efficacy for vaginal diazepam, and anecdotally, I have had quite a bit of success with it. So I continue to use it despite the paucity of evidence, and that's certainly something we could discuss later. Alpha blockers, the first report of this I was aware of was Dr. Anish Srivastava, whom I met last year as an AUA visiting scholar in Hyderabad, wrote about prazosin and terazosin and 24 patients, 6 weeks of follow-up, and noted a 50% response rate in these patients. So that started a lot of others investigating alpha blockers for these women. Of course, they're not indicated, and technically they're for men, but they work very well. So I think that's a reasonable option. Others have followed suit and published their own papers duplicating the results by Srivastava and colleagues. And so I think this is one option we can offer with minimal morbidity to the patients. Urinary diversion is something I offer for people with really severe types of Fowler syndrome and dysfunctional voiding. And I'll just close with a 70-year-old female who reports straining to urinate, recurring urinary tract infections, severe frequency, using lots of urinary pads, started on clean intermittent catheterization. It gave some benefit, but not enough benefit, still with a residual, had a history of lumbar spine fusion and did not have any evidence of sling or pelvic organ prolapse. And so the first thing I did was voiding cystourethrogram. She did have an opening bladder outlet. You can see that in the lower corner here, but she had very tremendous grade 4 hydronephrosis. So that's worrisome, suggesting that she's already got some upper tract damage. The creatinine turned out to be normal, but I believe that will progress with time. And the urodynamics revealed very high voiding pressures and active EMG, which I surmised was due to Fowler's syndrome, even though I did not use the needle electrode, and a very low flow. So what are the options for this woman? Well, her compliance was reasonable at 23 cc's per centimeter of water. And because of that, I offered sacral neuromodulation. But because of the clear upper tract harm that's going on, I also, for these patients, offer urinary diversion. In this woman's case, an ileal conduit. I don't want a continent diversion for somebody who's already got compromised upper tracts. And she did have a history of chronic kidney disease. And so if sacral neuromodulation, and I will reevaluate her 2 months after she gets their neuromodulation device, and if she doesn't have reduced pressures, doesn't have improvement in the hydronephrosis, then I would move to urinary diversion. So that's my talk, and thank you very much for your attention.
Thank you very much. We will have the question and answers later on. Can I invite Ajay Singla, who will be introducing Sanjay Sinha and take over thereafter.
Sure, Ajit. Good morning, everyone. Thanks, Charles, for that. That was an excellent talk. I'm also delighted to introduce one of my close friends, Sanjay Sinha. He's a very well-known name, both nationally in India as well as internationally. He's very active in IUGA. He's been on the International Urogynecological Journal editorial board. So Sanjay is going to talk about primary bladder neck obstruction in women. Sanjay, go ahead.
Good morning, everybody. And thank you very much for that. Thank you very much for that introduction, Ajit. Ajay, I'm so sorry. Got a little distracted. I had been asked to speak on bladder neck obstruction in women. And bladder neck obstruction in women is an entity which has been well described, but has been well described, but we don't have. We are aware of the anatomical and the physiological underlying basis of bladder neck obstruction. We know that the ring of musculature at the bladder neck in women is incompletely developed. We also know that it's less prominent. There's a low density of alpha adrenergic blockers receptors at the bladder neck. So this is all well described. But what is not clear is that the lack of commonality in making a diagnosis is because the condition is really very uncommon, or whether it's been a blind spot in our literature. So if you look at this think tank of the ICS, which published a paper on do we understand voiding dysfunction in women, current understanding. This paper actually listed a table of conditions which were associated with voiding dysfunction. And surprisingly, this table missed or omitted including primary bladder neck obstruction. So it becomes unclear whether our lack of making a diagnosis is because we are not really prepared to recognize that the condition exists. Because if the ICS think tank is going to omit it from their table of conditions, clearly there is a problem in our ability to keep the condition in mind. And what the mind doesn't know, think about, the eye doesn't see. But primary bladder neck obstruction does exist, and we know that way back, as Dr. Anand said, in 1995, they published in the Journal of Urology functional bladder neck obstruction as a rare cause of renal failure, and they showed that this was an uncommon cause, but patients could present in renal failure. So this is way back. I was a trainee at that time at Sanjay Gandhi at that institution, and so very long back this was described. So how do we suspect the diagnosis? Well, clearly, these are patients who present not just with voiding symptoms, but they can masquerade with storage symptoms. So it's important, women with voiding dysfunction can present with a mix of storage and voiding symptoms. And in some women, as with some men, the storage symptoms may predominate. The mean age in a recent publication was described as around 60, a little older than women with dysfunctional void. The maximum flow rates were lower than with dysfunctional voiders and with higher post-void residuals, as Charles also showed in one of his patients. Confirming the diagnosis, there's no real difference in the PDET Qmax between the various conditions which cause obstruction, but EMG activity tends to be increased in a large proportion of patients who have dysfunctional void as compared to patients who have primary bladder neck obstruction. Now, there are certain problems with EMG. Some problems have been just mentioned by Charles, but you know that EMG activity is a summation of all the pelvic floor activity and of all the aspects of lower tract evaluation. If there's one aspect of lower tract urodynamic evaluation, which is the least reliable, let me say, or is most subjective, it's the EMG activity of the pelvic floor, which is confounded by a whole lot of different things which happen at the level of the pelvic floor. Now let's take a look at this patient who presented with voiding difficulty and a video study of hers. And you can see here that she has a capacity which is on the lower side. She's got phasic contractions at the end of her fillings. She's got detrusor overactivity. But more importantly, let's come to the voiding part. And you can see here that as she voids, the bladder neck does not open well. So this is a patient who is voiding with a high pressure, a slow flow, and a bladder neck which is not opening well. And this is characteristic of patients who have a primary bladder neck obstruction. So how do you manage the patient once you've made a diagnosis? Conservative management might consist sometimes of observation alone, depending on what the patient's problems are. Alpha blockers, as Charles just mentioned, have been used in women with primary bladder neck obstruction. You would expect more than 50% of patients to respond, but that's the level of response which is seen here. And at this point, I do want to make a note of the fact that the literature with regard to bladder outlet obstruction or voiding dysfunction, I should say, in women is a very contaminated literature. I think different papers are talking of different sets of patients. I don't think that the diagnosis has been made precisely in many of these case series. And really it becomes, if you examine these studies carefully, you'll realize that when you try and apply this data to your patient, you can't really do it very well because these studies have not really made a precise diagnosis of the patient pool. So once you take a group of patients whom the diagnosis is not made very precisely, you land up with literature which is very difficult to use. So you find a 50% response in many papers for alpha blockers with primary bladder neck obstruction, with Fowler syndrome, with dysfunctional void. So literally with all the aspects of patients with voiding dysfunction, you find the same kind of a response rate. So I have a feeling we have a long way to go in making a precise diagnosis in these women. Intermittent catheterization is definitely one of the important management options, especially for patients who have severe obstruction or upper tract dilatation. And then, of course, patients who have a confirmed primary bladder neck obstruction, surgery may be an important method of managing these patients. The surgery consists of bladder neck incision, and in some patients, just like you resect the floor tissue in a patient with primary bladder neck obstruction, even the resection of a small part of the pelvic of the bladder neck. Let's take a look at this woman who is 52 years old to illustrate the condition, who has presented with voiding difficulty. It's refractory. She's bothered by it. She does not have upper tract dilatation. She has a slow flow, as you can see here. We often do a flow EMG in these patients, and you can see here that the EMG activity is silent with a slow flow. This is her urodynamic study, again showing a high pressure, slow flow, an element of abdominal strain. There's a slight drift in the abdominal pressure, but that doesn't take away from the fact that she's obstructed with a coordinated sphincter. And she had an MCUG done as a standalone procedure. And again, you can see during the voiding phase, she's not opening her bladder neck well. Now, in such patients, we have in very select patients, I think the number of patients whom we've actually done a bladder neck incision in my whole career would be less than 10. So we have done a bladder neck incision in some of these women. I often do this as an incremental bladder neck incision, where I make my first incision. And after making my first incision, which is a conservative incision, if required, I go back and do another procedure later after I have assessed the outcome of the first incision. So I'm conservative in doing this. I'm very comfortable doing it at the 6 o'clock position. I know that there are publications which have done it at different points in the clock, you can say, of the urethra, but I'm fairly comfortable doing it at the bladder neck at the 6 o'clock position. My first incision is typically about 15 millimeters or so into the urethra. And then if required under short anesthetic, it's fairly simple to go back and extend your incision just a millimeter or so, deepen it a little bit more. You can see here, this is a patient who's already had a bladder neck incision. And this is a post-incision view after a few weeks. And this looks exactly like a male patient. It will be difficult for you to identify whether this patient is a male or a female after the bladder neck has been incised. And you can see a good flow for this patient at the end of about, I think, 3 months or so when we did it. And as I said, about a 15 millimeter incision into the urethra. So unfortunately, unlike in men, you don't have a very good guide as to what is the length of incision you make in a female. You have no verumontanum to guide you. But usually if you're incising in this part of the urethra, you are reasonably safe. And it's uncommon to get it. At least I've never got into troubles of facing stress incontinence in a woman after a bladder neck incision. What is the outcome of this procedure? The first procedure typically has been shown to be successful in about 4/5 of patients, but there's a significant reoperation rate. So you need to monitor these patients to see how well they respond. And over a period of time, you might find that some patients will require an incremental or a repeat incision. There is a significant complication rate reported in literature, including VVF, stress incontinence, bleeding, and stricture formation. We've had a very small case series, so that really it's difficult to tell what would be the outcomes in a larger case series. But clearly, as with any other surgical procedure, you've got to be careful when you're doing this procedure, because small mistakes here, you don't have too much of room for error. Small mistakes here can lead to catastrophe. So I would close my talk by summarizing that primary bladder neck obstruction is a well-described entity, not diagnosed very commonly, accounts for about 5% or so of women who have voiding dysfunction. Perhaps it is underdiagnosed because many of these patients don't have the right diagnostic procedure done. To make a diagnosis, you must combine imaging with pressure flow studies in some way, ideally with a video or with a standalone intuitive combination with an MCUG. Conservative managements are the first line, but in patients in whom we have a confirmed diagnosis who are not responding, performing a surgical procedure for incising the bladder neck is a safe and an effective procedure for relieving the condition. Thank you very much. Back to the chair.
Thank you, Ajay. Kindly unmute yourself.
Yeah, no, thank you, Sanjay. It was really a good talk. As you mentioned, imaging is the key actually for diagnosing a primary bladder neck obstruction in women. You have to have a video urodynamics actually. But that was really a good session because I think Charles talks about more of a sphincter problems, and then you talk about mainly the bladder neck. I don't have any particular question myself, but I don't know if somebody else has any questions.
I have a question for Charles, if the chair permits me.
No, go ahead. Go ahead.
Okay. So Charles, do you really believe that Fowler's is a distinct condition? So I have certain problems with this. So I'm going to ask you a very candid question about this.
Of course.
If you look at the original descriptions of Claire Fowler, those descriptions of complex repetitive discharges and so on have been noted in a lot of normal women. It almost seems to me like glomerulations for bladder pain syndrome. So is there really a condition, or is it just a dysfunctional void, which is a form of dysfunction? What is it?
So Sanjay, I tried to politely discuss this with Dr. Fowler a number of years ago. And we had breakfast together, and I think we see what we see because of what we're comfortable with. And she is a neurologist and very famous, and I respect the work she's done, and she's provided a lot of useful stuff. I think there's a lot of overlap in the treatment. Now, the big distinction between primary bladder neck obstruction is, of course, you can incise that and they get better. With the Fowler syndrome, it wouldn't work, and it doesn't help these women. And I think sacral neuromodulation is much more helpful for the Fowler syndrome. So I believe it's a separate entity. I know it's very controversial. She probably wouldn't even agree that many of my patients qualify as Fowler syndrome patients because I don't use the needle electrode. But I bet if we take a show of hands amongst the panel, I'm afraid I'd just lose all my patients if I tell them I'm going to put a needle there.
Question, Ajit. Can I ask a question?
Yes, of course.
Yes.
Hi, Sanjay. I do the 6 o'clock cut even in males. Now, that's a fabulous way to open the bladder neck, I agree. But do you also incise the intratrigonal bar while in a very closed bladder neck, females?
And would I don't go that proximal at all.
You don't go proximal at all?
No, I don't.
So Shailesh, to answer your question, in 2016, there was a paper which was in American Urology Association.
Yeah, I know.
Precise way, how much you have to cut and you have to not cut. Probably not cut is much more important than to cut. So the way to go there was one of the person who first measured the bladder neck to the external meatus with the help of the resectoscope sheath. And he said that if 1/3 distal to that, if you cut it, you'll be fine. The proximal 2/3 should be left alone. That is probably way to go about. And there was a large controversy and there was a huge amount of uproar and many people gave a different opinion. But even today, I'm sure Ajay will speak on that, how much to cut and how deep is to cut. Because all of us cut at 5 and 7 o'clock position and not at 6 o'clock position like Sanjay. However,
I am just asking, anybody here in the panel goes towards the intratrigonal bar?
Well, I will
no. The bladder neck.
No.
Thank you.
It's very different. It's very different in men and women, how far you go proximally. True. Like Sanjay is saying, I don't go to that proximal in women. I don't do that many bladder neck incision in women, but certainly it is in men you can go onto trigone, but in women there is really no need to go because you're basically just the bladder neck only.
All right, thank you very much, both of you. Because
thank you again, guys.
The session, we are already 12 minutes late, and I, Ajay, Charles, and Sanjay Sinha for giving an excellent and very enterprising talk. Thank you very much.
Thank you.
Thank you, Dr. Waze, and thank you, Dr. Ajay, for chairing this session. We move on to the second session, second part of the session 2, which will be chaired by the experts, Dr. Deepak Kirpekar, Dr. Shalesha, and Dr. Ranbir. Over to you, sir.
Good morning, everyone. Thank you, Dr. Chawla, for this wonderful opportunity. It's a pleasure to be here today. Female urethral stricture incidence is very low. Still, we know hundreds and hundreds of women are being dilated on a regular basis, month after month. It is difficult to diagnose an exact female urethral stricture unless you do a dynamic MRI or a video urodynamics. But once it is diagnosed, I think urethroplasty would be a treatment of choice, which is done only once, and that will relieve the patient. My colleague Shailesh Shah is expert in female urethroplasty. He's done lots of cases. So Shailesh, I'll ask you to take over from this, and I'll chip in whenever required. Shailesh?
Thank you. Hello.
Yes,
can you see me? Yeah. Thank you very much. Now, the female urethra, for a long time, it was believed there is no stricture at all. But now it is last 20 years. There are a couple of publications and there are multi-systematic review of the article also. And female urethral stricture is a definite entity. However, the idiopathic stricture and traumatic stricture are altogether differently treated. As you said, not only in India, most of the world, lower urinary tract symptom of the female are being treated just by urethral dilatation. So if it is a stricture and you do dilatation once, it is fine. But if a patient comes again, they demand a lot of investigation and you have to rule out female urethral stricture. Simultaneously, once you diagnose a female urethral stricture, you need to do a urodynamic because it will be futile to create a conduit of passing urine in acontractile or severely underactive detrusor. So we have a different type of the technique of handling female urethral stricture. We can, if you have only meatal stricture, we do Hens-Mikulicz technique. In India, there are patients who are coming to government hospital where I work, Institute of Kidney Disease Civil Hospital, where they do not want to come regularly and they do not want a major surgery. Then we do even a meatal excision and make them hypospadias, so they will remain cured for a long time. But we cannot do in all the patients. These are only few exceptional patients who has a lot of financial trouble. The standard treatment is now buccal mucosa urethroplasty. You can certainly take vaginal free graft, which was the first article, I think in 2013 from SGPGI, where they put a multiple vaginal free graft for the urethroplasty. And vagina in every individual is not a normal because of the hormonal problem. So we need to use the other graft like oral mucosal graft. I invite Dr. Sarika Pandya because there are various approaches. We have a dorsal onlay, we have a ventral onlay, we have a dorsal inlay also, and we have a ventral inlay. And there are people who do the double phase urethroplasty. So when there are many techniques, you can understand people really do not know which technique is right for the patient. I'll request Dr. Sarika Pandya to speak about dorsal approach of doing female urethroplasty, and then we will have a discussion on ventral urethroplasty, and then we'll discuss or make some kind of a conclusion which will work well for all the patients. Thank you.
Thank you, sir.
Yeah, welcome.
Good morning, all, and happy Diwali. I would like to thank USI for giving me this opportunity. As we know that female urethral stricture is underdiagnosed and overlooked cause of female bladder outlet obstruction, but it represents 4 to 18% of the outlet obstruction in females. Causes are mainly because of the infection, trauma, previous instrumentation, prior urethral surgery, or radiation. There is currently no widely accepted definition for female urethral stricture, but a fixed anatomical narrowing between the bladder neck and external urethral meatus of less than 14 French caliber is diagnosed as a female urethral stricture. The surgical terminology used in female urethroplasty is confusing and required further clarification. Dorsal urethroplasty or a ventral part of the urethra is mainly based on the male urethroplasty. This is not logical in female urethra, as the ventral part of the urethra in female is pointing towards the vagina and the dorsal part of the urethra is pointing towards the pubic bone. So better to describe it as an anterior and posterior urethra. Usually this patient presents with the obstructive LUTs or history of frequent urethral dilatation. In these patients, gynecological examination is indispensable, as we come to know with examination by the presence of any periurethral abnormalities, pelvic organ prolapse, or a presence of lichen sclerosis, or even the quality of the local tissues which might be going to use for the reconstruction of the urethra. Ultrasonography with post-word acidic urine, uroflowmetry. In uroflowmetry, we found the plateau-shaped flat curve. Cystourethroskopy give us advantage to look to visualize the urethra, but we cannot measure the exact length of the urethra by cystourethroskopy. And sometimes in case of meatal stenosis or distal urethra, insertion of the scope may not be possible. MCUG give us a good view of the anatomy, like location as well as the length of the stricture part. In this MCUG, we found the dilated proximal urethral dilatation to the stenos segment with abrupt narrowing of the urethra of the stricture segment. Urine culture and sensitivity should be done, and before the procedure, and antibiotics should be given accordingly. Urodynamic study is optional in patients if it's a very high suspicious of the hypotonic bladder or presence of long-term diabetic status of the patient. Patient positioning in the lithotomy position, labia minora are retracted by sutures or a Lone Star retractor, and vaginal access is facilitated by the Dowen's vaginal retractor. This is a patient with ureteroscopy done with 6 French ureteroscope. Urethra is bypassed with the guide wire and ureteroscopy done. Suprameatal inverted U incision is taken. 6 French feeding tube is kept in situ. As we can see, the vagina is not that much healthy for a vaginal graft. The plane between the clitoral bodies and the dorsal urethra is dissected. Palpation of the pubic bone give us the proximal extent of the plane of dissection. The stay sutures are taken at the edge of the meatus on both the sides, and urethra dorsal urethra is cut up to the stricture segment till we reach the healthy urethra. This is the stricture segment. Reaching up to the proximal urethra. The buccal mucosal graft is harvested in between with the according to the dimension of the stricture segment.
and defatting of the graft was done. The graft suturing started from the proximal urethra coming towards the meatus. Graft edges are sutured with the cut edges of the urethra. Keeping the mucosa towards the urethral lumen. Suturing done. Including of the periurethral tissues are more important to give more fixity to the graft. Quilting of the graft done with the clitoral bodies. Quilting done. Suturing is done mainly with the 3-0 vicryl. At the meatus, the graft is approximated with the suprameatal incision suturing. This is completing the suturing. Intraoperative cystoscopy to confirm the graft placement. And the 20 French Foley's catheter kept in situ. Vaginal packing done for hemostasis, which is removed after 24 hours, and Foley's catheter patient discharged on the second post-op day. Foley's catheter kept for 3 weeks and 2 to 3 weeks, and asked for the follow-up for the Foley's removal. After the Foley's removal, first follow-up at the end of the 2 months with uroflowmetry and or cystoscopy. This is the cystoscopy showing the well taken up the graft. Thereafter, follow-up on 6 months and 1 year. So dorsal only approach is for female erythroplasty is described by the Osman et al. And his colleagues, and it found that there are multiple advantages on dorsal approach. It has a minimal graft circulation because of good mechanical support, lesser chances of developing a urethrovaginal fistula. There is a well-vascularized bed of clitoral cavernal bodies for the graft taken up. Avoiding the anterior vaginal wall, avoid the hypospadiatic meatus, and providing more physiological meatus facing upwards, and preserves the undisturbed ventral tissue for a possible future sling. Concerns with the dorsal approach are injury to the sphincter mechanism, resulting in incontinence, but stress incontinence did not occur in any reported patients, indicating that in practice, significant sphincter injury is rare. By staying more in midline, preservation of pubourethral ligamentary support, urethral mucosal coaptation mechanism preservation, and ventral suburethral hammock mechanism remains undisturbed. Another concern is injury to the neurovascular bundle of the clitoris, resulting in female sexual dysfunction. But a female sexual function is still poorly understood, and it is thought that the multiple organs, including labia, vaginal wall, urethra, breast, are all involved for the female sexual function apart from the clitoris as well. Clitoral body is a complex multiplanar structure, and it wraps the urethra in such a way that it will get injured during the ventral approach as well. So further studies are required in this prospect. So which technique is superior? No guidelines are available at present. All types of urethroplasty have a higher success rate, but all these studies have a short-term outcomes only. Vaginal flap, vagina or labial graft urethroplasty, and uromucosal graft urethroplasty. Success rate is varied from 91%, 80%, or 94% respectively. So robust studies are required, and the choice of technique at present depends on the treating surgeon's experience and preference. In my institute, in our institute, we are doing a dorsal onlay approach with the buccal mucosal graft urethroplasty. In conclusion, female urethral stricture is a known problem, but underdiagnosed, and majority are iatrogenic. Evaluation is by cystoscopy and VCOG. Urethral dilatation is the first line of management, but urethroplasty is a better alternative option as the recurrence nature of the disease and long-term outcomes are still unknown. Thank you.
Thank you, Sarika. Thank you very much for the presentation. We won't go for questions now. I'll request Dr. Pankaj Joshi to present his way of doing a urethroplasty, and then we'll ask questions. Over to you, Pankaj.
Thank you, Kirpekar sir, and thank you, USI and ISU for this opportunity. So I'm going to present with the liberty of my moderators, the topic being changed as an intra-urethral urethroplasty rather than labeling it as a ventral urethroplasty. We all know when it comes to anatomy, the ventral wall is that part which is anterior to the body. So technically, what I'm describing now is a dorsal urethroplasty, and what Sarika described was a ventral urethroplasty. There are a lot of papers in the literature which give a confusing terminology. The first time this was described, that is a posterior approach, was by my colleague, Justin Chi from Australia. He presented a video of a single patient. I'm presenting a representative video of a 37 years young female who had a catheter-induced stricture, multiple dilatations. It was an obliterative stricture. She would always come back with a poor flow, improves on dilatation with a high bladder pressure. The ideal instrument for doing a urethroscopy in a female urethroplasty is a mini nephroscope, and it has an angle of 5 degrees as compared to a ureteroscope, which is still about 25 to 30 degrees. It's a supine lithotomy position. I insert a small DeBakey's forceps inside. We can see the pale urethra, which is there. I'm using an ophthalmic scalpel. The advantage of using an ophthalmic scalpel is A, it is precise, and B, while recording a video, the forceps, the blade does not come in the way of the camera. So I'm incising bit by bit. I'm just incising the mucosa without going too deep. While doing this, I'm putting a finger in between the blades of the forceps and trying to open the urethra. We go proximally across the band of the stricture, and we create a bed which is almost 1.5 centimeters in width. One of our ways in which we check is to put a 24 French dilator, and if it walks in easily, we know we have gone across. I prefer taking a stay suture at 6 o'clock with an ethylon. So the idea is to pull the urethra out so a suturing becomes much simpler. Here we can see the urethra being pulled out. I'm holding the good proximal edge. My favorite suture is a 5-0 polydiaxone. Using an end-on technique of holding the suture, I take my first bite at 6 o'clock position. I'm just going to rotate my DeBakey's forceps, and I'm going to take another stitch at 7 o'clock position. I rotate my forceps anti-clockwise, and I can take a stitch at 5 o'clock position. This is just to insert a nasal speculum and see good flow of urine. I'm using a 5-inch needle holder, which is very small, and it is preferable when it comes to a delicate surgery. I'm going to give a tug on the suture and see that it is holding the mucosa well. Simultaneously, my colleague would harvest me a graft. I've requested for a 4 centimeter by 1.5 centimeter wide graft. The first sutures were outside in, so this is going to be an inside out suture onto the buccal graft. And now I'm going to parachute the graft intraurethral. So there is no incision on the urethral wall. The entire surgery is happening endoluminally inside the urethra. Once we have confirmed that the proximal sutures are well taken, I'm now going to start suturing the wall of the buccal graft to the wall of urethra. So this is the right side of the patient, interrupted sutures with 5-0 polydiaxone. The needle is a 12 mm needle, so it is very easy to move inside the urethra. And the two stay stitches on the urethral wall actually pull the urethra out. I'm now going to suture the left wall of the urethra to the edge of the buccal graft. And once this is done, I'm going to trim the excess graft and start suturing to the meatus. This is a stitch at 6 o'clock position. And then the lateral stitches. I've in fact gone from the graft into the vagina and back to the graft. There is very less risk of having a urethrovaginal fistula because the vaginal wall is very thick. So once all the 3 corners are sutured, I then start quilting to the underlying tissue. And here we can see a nice bed of 1.5 centimeter wide graft. So I have augmented the urethra by almost 15 millimeter on the posterior wall. I take about 5 or 6 quilting sutures. And this is the completed urethroplasty. With a nasal speculum, you can see good flow of urine. The problem is majority of the patients who are referred to our unit in Pune are for obliterative strictures. And if a male would come with an obliterative stricture, I would have done a double face urethroplasty. So I thought, why not do a double face urethroplasty for a female urethral stricture when they come with severe obliteration? I described one of world's first double face urethroplasty, and this is a representative video. So after having patched the posterior wall, we just rotate the nasal speculum anteriorly. And now I'm going to incise the anterior wall of the urethra from inside. So no dissection around the urethra. Both the walls can be augmented from inside. So this is a true intraurethral urethroplasty. I would make an incision with a width of about 7 to 8 millimeters. The trim graft that was there initially, I'm just going to turn it around. And here I'm taking a bite from the graft first and then from the urethral wall at 12 o'clock position. 3 o'clock position. And at 9 o'clock position. So the clitoral bodies are far away. The dorsal neurovascular bundle is far away. The entire surgery is inside the urethra. Now I'm going to anchor the graft to the meatus. The meatus looks a little oblique here because the urethra is pulled out. The moment I remove the stay sutures, the urethra goes inside. The lateral suturing, and then 1 or 2 quilting sutures. When we insert the catheter comes from the abdomen of the patient. So the catheter is going to help quilt the graft and keep the graft on the dorsal wall. So quilting is more important on the posterior wall versus the anterior wall. So this is a double phase intraluminal urethroplasty for obliterative strictures. 18 all French silicone catheter, which will stay for about 3 weeks. I have published the Joshi urethroplasty in the Turkish Journal of Urology last year. Now a follow-up of more than 12 months. And the ideal indication is for mid and distal stricture. If it is too proximal, it is very difficult to take sutures from inside. The video on my urethroplasty is also published at BJUI Knowledge. I thank Dr. Arun Chawla, USI, ISU, Dr. Kirpekar sir, and all of you all for a warm and patient hearing and for giving me this opportunity. Thank you.
Thank you, Pankaj. Thank you very much for a wonderful presentation. Shailesh, do we go for questions now? Because we have one more presentation remaining, which is by Dr. Raj Maheshwari. What should we do?
We'll finish this. We'll finish all presentation. Then you can give your expert comments.
Okay. So then we would like to invite Dr. Raj Maheshwari. I don't. Yes. I don't see her here on the.
She's there, sir. She's there. Yes, ma'am. Please share your presentation, ma'am. Please unmute, ma'am. We can't hear you.
Hello.
Yeah.
Am I audible, sir?
Yes, yes.
Okay. Okay. Do you have the screen?
Yes, visible.
Oh, okay. Can I go ahead?
Yes, ma'am.
Right. So this is about the pelvic organ prolapse, which is going to, which results in bladder outlet obstruction. There are different types of prolapse, and currently we use Professor John Delancey's level 1, 2, 3 gradations. And there are different stages of uterine descent. Along with that, there is also bladder descent. And we are just going to focus on the anatomical extrinsic factor of the POP, the cause for bladder outlet obstruction. Advanced prolapse can result in outlet obstruction, urinary incontinence, or detrusor dysfunction. So as a secondary to prolapse, there is irritative obstructive features compromising the voiding function. Apical prolapse, anterior, posterior prolapse, all these can result in outlet obstruction. But low-grade prolapse usually remains asymptomatic, and even a low-grade prolapse, as low as in 3%, can result in bladder outlet obstruction. Nearly 70% of women with significant prolapse, they have the outlet obstruction. There is also a contrary view that Coates et al. Says that most of the women with advanced prolapse void effectively. And it is proven by urodynamics that 30% of women who complain voiding symptoms only are proven to have outlet obstruction. So usually you can see the descent of the bladder, the MRI, and showing you the confirmation. But usually the small or less advanced cyst seal they have only stress incontinence, if at all. They don't feature with outlet obstruction. But the advanced larger cystocele with or without uterine prolapse predisposed to bladder outlet obstruction with a emptying problem. So ladies and gentlemen, you can see in advanced anterior wall prolapse, you can see how it results in the urethral kinking, which is responsible for the outlet obstruction. There is a complex relationship between the vaginal wall prolapse, anterior prolapse, and the voiding. And it is stated that funneling and opening of the retrovesical angle is associated with improved voiding rather than retaining the angle. There is also the huge rectocele as shown here in this picture can also result in outlet obstruction. And Peter Dietz and others have shown that even a enterocele can result in significant outlet tract obstruction. And it is also true that posterior vaginal wall descent with or without the fecal impaction can result in obstruction to the flow. With reference to the outflow tract causes, the urogenital prolapse contributes 24%. And another study says 12%. 12 to 24% contributes, the prolapse contributes to the overall causes of outlet obstruction. And you can see the symptoms, the incomplete voiding, reduced flow, are all more or less comparable to all other causes. This is interesting to see if someone does a successful urethropexy without correcting the proximal laxity in the vaginal wall or vault, over time, there results a gradual kinking of the urethrovesical angle, resulting in obstructive symptoms and irritative features. So this can be due to the urethropexy post-effect or due to the secondary prolapse or both. Ladies and gentlemen, and it is very important to reduce the prolapse and which can detect the mechanism of outflow tract obstruction and plan your proper treatment, whether to do prolapse repair alone or erythrolysis, that we can plan. So prolapse reduction per se can cause obstruction. And if you test it reduce it and check it, then you can watch the improved flow and the lowering of the pressure. Fitzgerald has shown that how trial of pessary can predict the outcome of surgery. So this is CMG and the pressure flow showing you with and without prolapse, showing how things were very bad before reducing the prolapse and how it has improved after reducing, and the flow is better. So prolapse can cause bladder outlet obstruction, which in turn can cause urethral obstruction and can even involve the upper tract. But plain cystocele and vaginal wall alone rarely cause hydrourethronephrosis and other things. One of the important feature is stress incontinence. With the advanced degree of prolapse, the sphincter incompetency is masked, because see, it happens up to 22 to 87% of cases, even though they have incompetent cervix, incompetent sphincter, they don't really reveal it. And once you correct the prolapse, then it will feature in the post-operative period. So it is important as clinician for us to reduce the prolapse, check it, and then counsel the patient whether they need a second stage. If needed, they have to be prepared mentally for that. So ladies and gentlemen, it is very important the role of pessary to counsel the patient, to plan a single stage a combined anti-incontinence procedure or a stage procedure. So after surgical correction, and I mean the patient otherwise will be very uncomfortable with if you don't counsel them properly. So greater degree of prolapse, say stage 3 or stage 4, will not have stress, particularly if the BA in the POPQ is if it is increased, that will be the cause for the obstructive symptoms. Regarding the lower urinary tract symptoms, urge incontinence is much higher in the presence of pelvic organ prolapse compared to without prolapse. Similarly, greater number of patients with prolapse have the OAB symptoms. And the Burroughs and Deeds, they said with less advanced prolapse, there are more urgency and urge incontinence. And in contrast, there are other researchers, they have said with advanced prolapse, the symptoms are worse. But postoperatively, irrespective of the stage of the prolapse, all these women restore their symptoms and resolve, all the symptoms resolve. So it is a chain obstruction and then increased resistance, secondary changes in the detrusor, and that results in trabeculation, and severe trabeculation is associated with the advanced pelvic organ prolapse. So sometimes there can even be detrusor underactivity. Whom to do urodynamic study? The guidance says that you need have to do for all the patients except in patients who have hydronephrosis, recurrent urinary infection, or if you are combining anti-incontinence procedure, you need to use your discretion and decide case by case. But simple cystometry with the reduced prolapse is needed if you are planning to do surgery, because that will help you to plan whether to do a single stage repair along with the prolapse repair, or counsel the patient about the need for subsequent anti-incontinence procedure. Now, what is the treatment? So irrespective of the size, stage of the prolapse, depending upon the type, whether it's a central defect or a paravaginal defect, so you need to restore the transverse attachment and then placate the pubocervical fascia. Facial repair is very good, and we use the 2-0, and you do a check cystoscopy subsequently. Usage of mesh is controversial, not in practice in day-to-day. And then with the full stage 3, stage 4 prolapse, you may have to do a hysterectomy and repair and reconstruction. Similarly, even with vault prolapse, you can see how the whole of the enteroceal sac with the intestine along with the bladder has come down. The upper half is the bladder and the lower half of the enteroceal. So all these cases should be addressed with not only vault fixation, but also we should take care of the sphincter weakness as well. Unless there are contraindications, surgery is the way to correct it, but the pessary can be used as an alternate, is a conservative approach in surgically unfit cases. Different types of procedures are there, and we need to remember that pessary has a diagnostic and therapeutic role in the management. So there are patients who are with irreducible, huge, massive procedentia-like. So you can use the temporizing or definitive options. Either you can try the PCN and then go in for the temporary pessary and then plan the definitive treatment. But I would like you, the audience, to know that in cases like this, where is the question of, trying to find out what is the cause for the obstruction? It is very obvious. Similarly, there is one more patient here in such massive advanced stage 4 pelvic organ prolapse, which is irreducible in this patient because of the fibroid, and in the other patient because of the multiple stones, not only small, all secondary stones, but also very big stones which are responsible for the obstruction. So ladies and gentlemen, so it is always important as a clinician to consider all the possibilities in our patients, not only the anatomically. So you can see how big the stone is there along with stage 4 prolapse in this particular woman. Ladies and gentlemen, I would like to conclude by saying advanced prolapse results in outlet obstruction. Not only the posterior wall, enterocele, rectocele, fecal impaction, all these will result in outlet obstruction. It is very important to address the incompetency of the sphincter, which also can be secondary. And over time, it causes kinking. So we need to do a pessary test, reduce it before subjecting the patient for a definitive treatment. And pessary is reserved and it has both diagnostic and therapeutic value. And for definitive solution, if we need to focus on the repair reconstruction, particularly the fascial repair. So it is also observed that a higher grade of prolapse is associated with OAB symptoms, trabeculations, detrusor overactivity, or even detrusor underactivity. Majority resolve after correction. Thank you very much.
Stop share.
Stop share. Stop.
Thank you very much, madam, for a wonderful presentation. Shailesh, you want to take over from this? My comment is basically if we do visit female urethral anatomy, it's a 4 centimeter long tube surrounded by 2 layers of smooth muscle, which is longitudinal inner layer, circular outer layer, supported by striated muscle, which is horseshoe anteriorly protecting, supported by the clitoral complex. If this is all into the anterior area, why dissect there? Why not ventral, which is much safer, a very thin layer? From the talk, I realized that they would not want to touch ventral area because they want to preserve in case they want to put a sling in later on. But that when we go through the dorsal aspect or the anterior aspect, going through all these mechanisms, after a good repair of a stricture urethra, maintenance is only bladder neck. Is that right? Just a question to the audience. Ventral would be a much better approach, maintaining all the sphincter mechanisms of the female urethra. That's what I felt. I want comments. Shailesh, you've been doing a lot of things. I want comment from Shailesh Shah. Shailesh, your speaker is off. You're muted.
Please unmute, sir.
Yes.
Please unmute.
Yes. What is your...
Shailesh, please unmute. Yeah.
I have unmuted. Am I audible?
Yes, you are audible.
So Dr. Deepak, thank you. What I understood that from both the presentation, you prefer so-called ventral vaginoplasty. Now this itself is there is no, at the moment, there is no consensus in the technique. And even in 2020, the urology journal are giving the question whether it is dorsal is good or ventral. But people are actually afraid of looking at the dissection on the dorsal side because it is vascular. And some of them say that clitoral anatomy is disturbed. Now there is a very clear-cut clitoral dissection is done, which is a multiplanar structure, and clitoral nerve comes just below the inferior pubic bone, and it is visible by open eye. So when we dissect the dorsal side, it is impossible to image the clitoral anatomy. And there is an article by Cutter where they have nickel cutter, they have assessed the sexual satisfaction after the dorsal graft. So that is the advantage. And second, God has given urethra in such a way so that there is an angulation of the urethra anteriorly. So when they sit down, or and void, the stream goes far away and it doesn't fall on the field. It is myth to say that by cutting neurovascular bundle on the dorsal side, you get incontinence. In fact, people have cut the entire urethra and they are not incontinent. There are various literature survey and it says there is no single individual who has become incontinent after dorsal approach. My bias is for the dorsal approach. I have done several ventral approach also, but the biggest problem if they come with the SI later on, then the dissection is difficult. And when I go inside beyond the mid urethra, the dissection of on the ventral side is difficult. So personally, I will prefer the dorsal approach. However, it all upon the surgeon's choice, their expertise, and the kind of the cases they are in. So that was my opinion, Dr. Deepak. And we had a discussion bladder outlet obstruction due to ureterovaginal prolapse. I have a question to Dr. Raj Maheshwari. Every single patient who has a significant prolapse will definitely have a ureterovaginal obstruction, bladder outlet obstruction.
Sir, I think most of them, yes, because it all depends upon the kind of prolapse cases you see. In our referral practice, we see mostly advanced stage 3, stage 4 prolapse cases. And 70% of them are expected to have some kind of outlet obstruction. And the less advanced, merely a cystocele kind of anterior vaginal wall prolapse, not necessarily they are related to it. So the higher the prolapse, the staging or level, and then the higher the chances of seeing the outlet obstruction.
No, but the management part remains the same. I have to ultimately reduce the prolapse. Then why should I bother about BNO?
So it is, the bladder is an unreliable witness. And the previous speakers have said that even in outlet obstruction, the storage symptoms will be present like. So this, if you're going to analyze symptoms, then definitely it is not going to lead us whether it is kind of obstructed or a leakage problem. But still, I think it is, even if it is obstructed, it is going to present with the leakage problem. So the significant obstruction is anticipated in 70% of the people. So invariably they will resolve after surgery. So it is not going to alter your management, but it is for your understanding.
Yes, ma'am. No, I had just inquisitiveness that have you ever done bladder neck incision or kept the patient on CISC after reducing your prolapse?
I think I have not done bladder neck incision for cases of pelvic organ prolapse, but I have done it for primary bladder neck obstructions, but not for pelvic organ prolapse. If there is pelvic organ prolapse and obstruction, definitely I will focus my attention and treat, either temporarily check it with pessary or going for a definitive treatment with repair reconstruction rather than thinking of any other things.
Thank you very much.
Yeah.
I'm particularly thankful to Dr. Arun Chawla to include me in this discussion, and thankful to USI. I give over to my senior Dr. Deepak Kirpekar.
Thank you very much, everybody. For
Dr. Deepak, please. Yeah.
But again, we are running short of time, so I don't want to say anything more. Thank you.
Sir,
Thank you, Dr. Chawla.
Yeah.
I hand it over to you.
Sir, I'll just take two quick questions from the chat section. The first question is to Pankaj. I think it was Mild discussion was there in the chat section also. Pankaj, question to you. There's no spongism in female urethra. So what is the advantage of going inlay rather than onlay? Pankaj, are you there?
Yeah, the only advantage is we don't want to dissect around the urethra when we can do the same thing from inside the urethra. So eventually when you do an approach anteriorly, open the wall and put a graft, when you suture, it crumples. Versus you are doing the same technique from inside, which is much more minimally invasive as compared to dissecting the whole urethra. So anyway, the graft never touches the sponge if you're going to quilt it. So that is the only advantage, it becomes minimally invasive.
Second question to Dr. Rajmaheshwari. This is a question from Jyotha Philipraj. What is the importance of uterosacral ligament and cardinal ligament in voiding dysfunction with prolapse?
I think these ligaments are connected in connection with the supports of the uterus. So the defect in the ligaments will permit the descent of the uterus. So the cardinal ligament and uterosacral ligament, they offer the level 1 support to the apical compartment. With uterus, it becomes uterovaginal prolapse. Without uterus, it will become either wall prolapse or enteroceal. So all these will be repaired at the time of reconstruction done during the prolapse surgery.
Yeah, thank you, ma'am. And just Pankaj and Sarika, I was just seeing the excellent videos. Now, what usually I do in my experience, it is either a dorsal onlay or a ventral onlay, but this is not with the free graft, but with the flap. What happens is usually the strictures are metal or up to mid urethral. So where I feel a dorsal is much comfortable. Sometimes I use a ventral onlay flap in women who are little what you can say narrow, little narrow pelvis with a low BMI. Again, the putting a flap is much more convenient in these women. Only thing is you have to assess the vaginal capacity, because you are doing a vaginal flap exactly like a male or ND. So you are having a rectangular flap up to the level of sticker and just beyond that, and you just mobilize on one side and roll it over. It's a very convenient, but only thing is you should just make sure that vagina is little capacious, because one wall of the vagina has to go to the opposite side, which is deficient of around 1.55 centimeter of a vaginal wall. That is the only issue, but results are equal.
Thank you, sir.
Thank you, the chair. Thank you, the experts. We move on to the next session, which is the last session on the case scenarios. May I invite the experts and the chair to please join in. May I request now Dr. Ajit Waze, and Dr. Charles Powell, and Dr. Lalita, Dr. Salesha, and Dr. Shirish Rande to take over for the case scenario session. Over to you, sir.
So let me begin with it. Thereafter, the Charles will take over. So let's look at the first case.
Dr. Ajit?
Yes.
Just one request. If we can cut one minute time for every speaker so that we can finish on time.
How much time do you want per speaker?
Sir, we were to start at 12:10. We are 10 minutes.
20 minutes late. Correct.
Yeah. No, we are 10 minutes ahead. Yeah. 20 minutes ahead.
I'm going to request Sanjay Sinha to present the first case of female child with LUTS with DVD.
Thank you very much. I hope you can hear me.
Yes, we can.
Okay. So I just have 6 slides here, so we can easily adjust the time. So I've been asked to speak, discuss a case of dysfunctional voiding in a child, in a female child, and I have no disclosure. So these are the case details. A 7-year-old girl presented with urinary incontinence initially elsewhere in 2016. She had no major voiding difficulty. She had an ultrasound scan which showed a low post-void residual. She was put on antimuscarinics with limited success. She then presented 4 years later at the age of 11 with urinary incontinence and a poor stream, 1 episode of a presumptive urinary tract infection a year ago with chills and dysuria, chronic constipation, evacuating twice in a week, no clinical stigmata of a neurological disorder, ultrasound showing normal kidneys and a post-void residual of 70/240 ml. Her voiding diary shows 10 voids in 24 hours with 1.3 liters urine volume, a mean voided volume of 130 and a maximum voided volume of 300. She had 3 episodes of urinary incontinence, 1 episode of enuresis, and no nocturnal polyuria. This is her uroflow rate, a tube-free uroflow. Right. Now, I'm going to put the questions to the panel. I'm sure I'm allowed to do that. So now let me ask my panel. Charles, would you say that this is consistent with the diagnosis of dysfunctional void?
I would. She appears to be abdominal straining by the sawtooth pattern you see on the uroflow.
So can I ask the rest of the Shirish, would you say that the sawtooth or staccato so-called pattern that we find in dysfunctional void is because of abdominal strain, or do you think it's because of striated sphincteric activity, or what do we attribute this to?
It's highly suspicious of staccato voiding because of sphincter overactivity. But I know what we need to do basically is to watch the girls voiding, and that is the most important thing as far as I'm aware. And again, one cycle showing this does not mean anything, because the patients are anxious, they don't know how they actually voided at that time. So I think the best thing is to ask the mother, does she strain while voiding? And then you watch her voiding at least once, and then have at least 2 or 3 different dressings and see what you want. Of course, this is really suspicious of a sphincteric obstruction, no doubt about that. But it could well be abdominal straining.
Sorry, with no dissent from any of the other faculty, I'll assume that you're all agreed that this is consistent with the diagnosis of dysfunctional
It's
void.
very difficult to see.
Sanjay,
just by looking at it.
Ajit.
Yes, I think we need some more imaging investigation in her, especially.
Yeah, I mean, I said
that's true.
On the face of it, is it consistent?
Based on the history?
Yeah, and that flow. Right. So the ICS defines dysfunctional voiding is characterized as intermittent and or fluctuating flow rate due to involuntary intermittent contractions of the periurethral striated muscle or levator muscles during voiding in a neurologically normal individual. It's a mouthful of a definition, and I have some with this. So let me start by asking my panel, do we have Ajay there? Ajay, the ICS says that you should get an intermittent or fluctuating flow. We have not always found this. I mean, you can see here that there are patients who do not show this intermittent staccato kind of a pattern. In fact, one of the cases that Charles showed, that case also had just a sustained slow flow rather than a kind of staccato pattern. So do you feel that this is important?
No, I think you could have any variety of flow patterns, actually. You can have, yes, most commonly you would see intermittent flow because of the intermittent contraction of the sphincter muscle, but you can certainly have a smooth flow also. I've seen smooth ones also.
So Lalita, would you agree? Would you make a diagnosis of dysfunctional void in somebody without a staccato flow, just a slow flow? Lalita, are you there?
We heard our voice just now.
Shailesh, you can take that short, quick answer so we can go on to the next point. Okay, right. The other aspect that I find difficult is when this definition is the concept that it's the periurethral striated or levator muscles which are involved. Now, the problem that I find is that. Oops.
Hi, Sanjay.
Hi, Lalita. Go ahead.
Lalita here. Yeah. Am I audible now?
Yes, you are.
Yeah. See, the staccato pattern is a characteristic of dysfunctional voiding, but sometimes the external sphincter can be overactive continuously.
Right.
There are different patterns of sphincter overactivity. Sometimes it's a continuous overactivity. So there can be low flow continuous pattern.
Right. So the other aspect is regarding the requirement that it's a periurethral striated or levator muscles which are at fault. Now the problem is the current technologies that we use for lower tract evaluation, they really fail to distinguish the precise location of dyssynergia, whether it's intramural or mural or periurethral. There's no way in any of the tests that we do to differentiate between an intramural striated sphincteric dyssynergia and a periurethral striated sphincteric
Absolutely.
dyssynergia. There's really no
Absolutely.
method
That's very
to differentiate. So let me now just ask Charles a quick response to this. Charles, do you believe that there is any method by which we can actually make a precise locational diagnosis of the problem?
No, I think our best is video urodynamics, but I'm not aware of anything.
So
I'm open to
the problem,
panel's
Charles,
opinion.
with the video is whether it's video, whether it's UPP, they don't really differentiate. They can tell you the level at which it's happened, but essentially whether it's intramural or periurethral, really none of them actually tell you that.
Yeah, there's no way to know, in my opinion.
Right. So as Shirish was telling, there are many possible causes for dysfunctional, the staccato voiding. So don't attribute staccato voiding to a dysfunctional void unless you have looked at many of the other things, including an uncomfortable child, before you make a diagnosis. Right. So the other aspect is that this has been described as a learned disorder, something that people have, it's a faulty learning technique. And it's also possible that inappropriate toilet training, urgency, discomfort, constipation, all these things can actually lead to this, and it may even have a behavioral component. A recent publication by the ICI think tank suggested that OAB symptoms which are not controlled can give rise to a kind of voiding postponement urgency, and that can trigger some kind of a dysynergic sphincteric activity, which presents as dysfunctional void. Now, I'm going to ask my panel now, and maybe somebody who's Shailesh has not come in so far. Shailesh, you know, there are some patients who present later on in life with the first symptom of a dysfunctional void. They've never given a history that they actually had a problem through their childhood. So how do we really explain this kind of dysfunctional void? They've clearly not unlearned what they knew to suddenly learn something wrong and start voiding the wrong way at the age of 30 or 40 years. So what do you think? Is it that they had symptoms, they didn't identify it, or is it something new happening in some of these patients?
Can I answer that?
Yeah, sure. Go ahead, Lalita.
Yeah. See, in some women, it could be a childhood problem which got. Yeah,
Oh, it was, I meant, I don't know which Shailesh is part of the panel. Is it Shailesh Shah or Shailesh Rana?
Okay.
So,
Lalita, go ahead. Quick answer.
yeah, in some children, in some women, it could be a problem which persisted throughout the childhood, which was not been identified and corrected. But in some young women, which I very commonly see in my practice, it is, I'm sure the experts here would agree that it's more of a social problem too, especially in a country like ours. Many of these women confess to their habit of the need to postpone their need to void.
Right.
Because of the the lack of clean restrooms, they're habituated to postpone the need to void, so that is going to actually cause this dysfunctional voiding.
So Glasberg in 2016 had an interesting publication. He looked at 77 patients each of patients who were classified as OAB, children who were classified as OAB, and children who were classified as dysfunctional. And then he tried to see whether there was a crossover of children who were initially diagnosed as OAB, who went on to become dysfunctional. He didn't really find any evidence of this. So although it is conjecture, we still don't have a clear proof. The other was that the mean age for the two groups was the same, which you wouldn't expect if it's OAB transitioning in some children into a dysfunctional void. The next issue is regarding the fact that these children should not have a neurological diagnosis. The problem is that we know that some forms of occult spinal dysraphism, a T-third cord, these can actually present as dysfunctional void, and they may not be anything apparent on a clinical examination. More intriguing, there is the entity what is called as the occult dysraphism. The occult T-third cord, where actually the spinal cord ends at the right point around L2 level as usual, but despite that it's considered to be T-third, because we know that there's a variation in where the spinal cord actually ends. And to cut a long story short, some investigators have divided the phylum terminal in such patients and shown improvements in voiding function. Charles, do you believe that what proportion of your patients would you consider for imaging, or what would trigger an imaging, Charles?
Well, I do see some children and adolescents, and so if they've had a sudden change, especially between the ages of 8 and 13, I worry about that. But in adults, I very seldom, unless they have a cauda equina syndrome, I don't usually look for this, and perhaps I should be.
So in children, would you image all children who present like this? I mean, because
No.
yield is not good. So what triggers imaging in your department or in your algorithm?
So a sudden change in their mobility or sensation in the lower extremities, which might suggest a tethered cord, and that's usually what I'm looking for. I very seldom am looking for occult dysraphism. That usually, we have a large children's hospital, and they generally come to us with that diagnosis already.
So you wouldn't image the spine unless you find somatic nerve abnormalities. Is that right?
That's right. That's right. I typically don't.
Okay.
Sanjay.
Ajit.
Yeah. Because of the time constraint, I would request you to just summarize this and.
Sure. Okay. Right. So this patient was put on antimuscarinics, initially tolterodine and solifenacin, was put on tamsulosin, a small dose, given bowel care because she was having significant constipation and was offered biofeedback. If we have, do we have time to discuss about the management option, or we go on beyond this? I am not very sure where we stand. So she
can go beyond that.
Okay. She continued to be symptomatic, both in terms of voiding.
Quickly summarize, Sanjay. I think it's better.
Shirish. Yeah.
Yeah, I think quickly summarize. Yeah.
Okay, right.
Because it look better to be complete.
Okay. So at this point, because this child was not responding, we went ahead and did a urodynamics for her, and you can see here that she does have a significant dilatation of her proximal urethra when she voids. She has no reflux. The bladder morphology looks okay. And in general, in patients who have got no upper tract changes, we would be less aggressive in managing, but at least some of these children, if they've got upper tract dilatation present, some of these children, at least in my book, would go on to intermittent catheterization. In our experience, use of biofeedback techniques, or even botulinum toxin for that matter, in children with upper tract changes is probably not the right way forward, because we know botulinum effects wear off very quickly. It's striated muscle, and over a lifetime, injecting every 3, 4, 5 months for such people children who've already got upper tract dilatation doesn't sound very sensible to me. So that's where I think I will stop at this point. If the experts would like to give any further comments on this case,
we will come back to you, Sanjay, because of the time constraint.
Sure.
May I now request Ajay to give us his second case, please? A TVTO with LUTS post-operative.
Let me just try to share the screen.
Okay.
Can you see my slides?
No, sir.
No.
Oh.
You are not sharing the screen.
Let me just try it.
Oh, just
share screen. Share screen again.
Open your presentation, then share your screen, sir.
Just go at the bottom of the screen. There is a share screen option. Just click on that. You probably get the.
No, I am clicking that one. Let me see.
All right, give a talk and we will explain. we'll go ahead.
Give it another chance, Ajay. Give it another chance. Share screen and then box share screen again. Yeah.
We can
When
go
the box
for.
comes, you just click.
No.
The box.
Let him. Let him settle.
To,
let us ask Dr. Pavan Vasavda to present.
You have to allow me. Actually, you have to allow me to share the screen, actually, because it's not allowing.
You organize yourself. Yeah.
Let's move ahead.
Ranjit, can you just check why he's not able to?
While Ajay is
yes, so just stop your screen and just reshare your screen. Just stop screen and reshare your screen again.
Okay, let's try that.
And first open your presentation, then share your screen.
Yeah, my presentation is open actually.
Yeah.
So maybe a double click on the share screen, please.
No.
Okay.
Single click.
No, single screen, single click. Sir.
Single click, and then other click on the in the box. Move ahead while he's sorting it out.
Okay. So
yeah, go ahead.
Yeah, we will request Dr. Pavan. Is Pavan around?
Is
Yes, sir,
Pawan
I'm there.
online?
Yes, sir, I'm there.
Yeah.
Okay,
Pawan, go ahead. Yeah.
So
go
my,
ahead. Yeah, go
yes,
ahead.
so, sir, I'll just share my screen. It's working
Great.
now. There was a problem earlier. So, yes, sir. So, we'll start with this case. So this,
But
sir,
you're
can
not
you hear
seeing the
me?
screen. You're not
So
seeing
once,
your.
Yes,
one,
Pawan.
so 1 second. Can you see the screen now?
Yes, sir.
Okay.
Yes,
So,
go ahead.
so sir, this was a 50-year-old female, had a traumatic cervical subluxation 5 years back, was operated. It was an incomplete spinal cord injury. Now, after a period of initial indwelling catheter, she's been voiding on her own. She has irritative and obstructive LUTs all these years with frequency, urgency, and urge incontinence. Now, recently, she had an episode of UTI for which she received a 14-day antibiotic course from her GP, who also then asked her to go meet a urologist, and that's how she came in. So, sir, how would you want to proceed? Would anybody want to take this, Dr. Shirish?
You can throw it open. Shirish, would you comment on
And
that?
she's voiding normally, is she?
She's voiding
I
on
think
her own.
there's we need some baseline workup. No, she's voiding, but is she voiding well? That's the main problem I have, and I think we haven't got an ultrasound here. We haven't got a voiding diary, and we haven't got a urine culture. I think all the three.
Ajay, what would you think in terms of clinical?
I would do culture, a full ultrasound, including PVR and a voiding diary. Yeah.
Okay, so for the sake of time, I'll just move forward. So physical exam, her higher functions were normal. She's a walker. Her hand dexterity, she's CIC capable. She had bilateral leg swelling. Anal tone was present. BCR was present. Bladder diary, the output is 1.5 liters a day. Frequency eight times. Most volumes were 200 to 250. She leaks it, and between most of the volumes, she was leaking. Urine analysis, which is normal, and this is the ultrasound. She had bilateral hydroureteronephrosis, ureters dilated till the lower end, right more than left. The cortical thickness was decreased more on the right side. Pre-void 350, post-void 180.
What is serum creatinine?
Which is 3.1.
So obviously, I think we have a problem. He's got a responsible for
this.
Yeah.
Why serum creatinine was done at last?
No, I mean, this is all the investigation that were done. This is what was written at the first go, and this is what she came back with.
Okay.
So, Dr. Ajay, how would you want to take this further?
Sorry, Pawan, are you talking to me?
Yeah, that's
yes,
right.
I'm just trying to figure out my share screen.
Okay, so anyway,
Can I start the discussion? I'm
Yeah,
Dr. Lalita
please.
here. Yeah,
Please
Pawan.
do.
Yeah,
Yes, ma'am.
I think with a good antibiotic cover, we need to directly go ahead with the urodynamic study in view of her history of spinal injury.
So, anybody differs with this approach? Dr. Vaze, please.
I think we need to do Valsalva leak point pressure in order to find out whether it is a dangerous bladder or not first.
Okay. Dr. Charles, would you agree to go ahead with the video aerodynamics at this stage?
Yes,
I will keep an indwelling catheter for 2 to 3 weeks, and then I will see whether the renal function reduces or not, and it will give me a kind of a therapeutic direction, and then I will go for urodynamic.
Dr. Charles would agree?
Hello?
Yes, I would agree with that.
Yes.
Okay, so this is what was done. We put in an indwelling catheter for a couple of weeks. Creatinine normalized and stabilized to 1.1. And subsequent to this, we did a video urodynamics, which I'm just, I hope this plays. Yes. So this is the quality control in the beginning. And if we So this was one involuntary detrusor contraction. So during the filling phase, the pressures are consistently rising along with neurogenic detrusor overactivity. If you see, there is right side
33
as well, and the bladder contour is also not the best. Now she filled to about 350, and the pressures went up to end filling pressure was about 45, 47. This is when we asked her to void. And if you now look at the pressures have gone to about 90 to 100. And if you look at the urethra, this is what we have.
Okay. So I think Pawan, we are first of all, my comment is she has neurodegenerative overactivity associated with lower compliance.
So we so this right side high grade reflux was there in the static also, but if you look at the left side, there was some reflux that came in when she started voiding. So this is the urodynamic trace. Does anybody want to take this?
Yes, Pawan. I think we are. First of all, there have to be some artifacts because of the catheter being present there. We have to understand that in mind. Secondly, I think if you don't take it into account, we are dealing neurogenic overactivity associated with a reduced compliance with leakage. And when you ask her to void, she has a distinct element of detrusor sphincter dyssynergia leading to high voiding pressure. And in
Just summarize. This.
Along with reflux on the
yes.
side,
So the capacity was about 360. We saw there are multiple NDOs. The amplitude of which is less than 40 in most cases. Feed pressure 45. Poor compliance. She did not during the study, and this was the voiding films. So we also got a baseline. And the right kidney GFR was 24 and the left kidney GFR was 68. Dr. Charles, would you want to take this on how, what are the issues at hand and what we need to do?
Yes, she has a high pressure, non-compliant bladder and already with reflux, looks like grade 3 or 4 on the right and grade 1 on the left. This is the picture one sees with something like a myelomeningocele. She's 50 years of age, so it's quite possible she carries an occult diagnosis of spinal dysraphism. But I think we need to talk about trying to release the bladder outlet. I don't know that I saw a nice funneling of the bladder outlet, and I would worry about urethral stricture since it stopped abruptly at the sphincter. But this is not a case of primary bladder neck primary bladder outlet obstruction, since there was a nice funneling of the urethra. Possibly Fowler syndrome, possibly spinal dysraphism.
So in the history, she already has a history of a cervical subluxation 5 years back.
Ah, okay.
She was operated. So this is what we thought, that she has a suprasacral incomplete spinal cord injury with a bad bladder. And so how would you like to proceed, Dr. Vaze?
She is obviously need a CIC. And either she's 50-year-old, right?
Yes.
She is mobile and she is
CIC capable.
Yeah, she is very capable of doing a CIC. We have to first tell her that if you don't control this high bladder, it is going to, as it is, her creatinine is 3.1, probably suggestive of or the impending renal failure to begin with. She has a large reflux to begin with. So she will have to undergo a CIC, but at the same time, I would just tell her that a Botox injection also is probably needed in addition to that.
So we all agree
No,
that
before we Botox, we have to actually reduce the pressures, maybe pharmacology and screenings along with CIC before we go in for Botox.
Dr.
Yes, sir. Yes, Dr.
I would keep the bladder augmentation procedure as a last. If everything fails, then probably bladder augmentation.
Dr. Shailesh?
I didn't say augmentation, sir, pharmacological.
Yeah.
Just
Okay.
reduce the pressure, storage pressures.
Patient had already renal failure to start with, and you kept the catheter and it became creatinine of 1.
Yes.
Most of the Indian patients are not compliant of very regular CSIC. If you find out the one, she is a regular and she comes for a 3 monthly or 6 monthly MCU and serum creatinine, then it is fine. Otherwise, I will offer her a claim cystoplasty.
Okay, so we all agree that self-voiding should not be continued. Now, if CIC, this is was my this is the question that I was coming to, Dr. Ajay. In cases who come a little late, would you still advise following the traditional pattern of antimuscarinic, then botulinum, and then augmentation, or would you skip to another step straight on?
Well, we usually still follow the traditional route, giving the medications. But I tell you, the hope will be very less. She probably would move on to the third line treatment.
Okay, so this is what we did. We started around 4-hourly CIC solifenacin. I'll just finish this and come back, sir. Okay, so we started on 4-hourly CIC and solifenacin, 10 milligram. Incontinence persisted. Added mirabegron, which may be off label as of now. Again, incontinence persisted. So, Dr. Charles, when do you label your NDOA patient as refractory? I mean, what would be your criteria to label a patient refractory?
I try 1, possibly 2 anticholinergic medications for 30 days.
Okay. Yes. So currently there is no consensus on whether it should be a single anticholinergic or 2, or add with mirabegron, or various combinations. So there is no consensus on what would be labeled as refractory. So this lady went on to get. So if this does not work, Dr. Lalita, what would you do? She didn't respond to antimuscarinics. And
yeah, after no, we label someone as refractory only when we give a combination of antimuscarinics and mirabegron. And if she's still not responding, her pressures are not coming down, then that's the time we go in and give a botulinum toxin.
How much botulinum toxin would you want to give?
Yeah, actually, in this lady, we would give both intradetrusor as well as intrasphincteric.
Okay, and how much?
200 units intradetrusor, 50 units into the sphincter.
Okay, so what we did was we gave her 200 units of onabotulinum toxinase. Subjectively, she improved. Now, would you, Dr. Ajay, would you routinely do urodynamics for patients who improve subjectively?
Yes, I would. Actually, I would, because you don't know what the pressures, even though she may not have a clinically symptoms of incontinence, but probably you would not know what the pressures are doing. So I would repeat the urodynamics.
At what time, sir?
Yes.
Oh, you mean after the botulinum toxin? So I would wait 6 to 8 weeks, or at least even 3 months even.
3 months.
So this repeat study was done at 3 months, which showed that the pressures had stabilized. Now I have a question: if CIC through the urethra is not possible, let's say she was wheelchair bound or very heavy, or so what do you think are the options, Charles?
So in this particular patient, I would be more ready to perform urinary diversion with an incontinent diversion, such as an ileal conduit, because they've already demonstrated some renal insufficiency, and that will come back as soon as they develop high pressures for long periods of time. And so I don't trust caregivers to catheterize patients, and indwelling Foley catheters, although they're easy, they can cause long-term problems.
So if somebody is CIC capable, but let's say she's wheelchair bound and obese, so there are would you consider a continent cutaneous?
Yes, I would.
You would. Okay, so that's something which. And would you consider a bladder neck closure when you do these mitrophiles?
Yes.
You would routinely close the bladder neck?
No, not really.
No.
I wouldn't.
if something happens to your Mitrofanov or your catheterizable stoma, at least you have a sort of a pop-off valve from below. So at least you should.
Yes.
I would do that. Yeah.
Okay. And sir, if
one last question to Dr. Charles. We were thinking of conduit diversion. Why not think of augmentation with Mitrofanov? Isn't that a better choice for the patient?
that was for somebody who cannot do CIC.
If this is somebody that
CIC is what? I mean, with the Mitrofanov on abdomen, CIC should be immensely possible. Even for
No, I mean,
this individual.
So that he mentioned for somebody where CIC is not possible.
Okay. Okay.
So, sir, if CIC is not possible, Dr. Vazi, what do you prefer? Do you prefer an indwelling urethral or an indwelling suprapubic?
Well, CIC is not possible. The indwelling catheter, we have already put it for 6 weeks and it has shown the result, but no. We have to talk to the patient, tell her what are the problems of indwelling catheter for more than 6 weeks time vis-a-vis the suprapubic. But suprapubic has its own problems too.
So, but between the two,
I would prefer an indwelling suprapubic if CIC is not possible or difficult to do because of her conditions, or there is no person who is helping her, or she is grossly obese. If there is a manual dexterity is a problem, so probably a suprapubic indwelling would be a failure. But certainly, in such situation, better than indwelling suprapubic, a continent diversion procedure in form of Mitrofanov or Monty would be a good and ideal choice.
So this was a very elegant article in 2000 which showed that for about an intermittent catheterization has the lowest risk, and then those who use those who are spontaneously voiding. Between the CIC and the urethral, the orange one is suprapubic, and the red one is the urethral. Yes. So in about 20 years, the suprapubic catheters have much less morbidity when compared to the urethral catheter, and after about 20 years, then they tend to come close to each other. And of course, the last option, as Dr. Charles mentioned, would be a supravesical diversion, whether a continent urinary or a wet stoma. Yes, thank you.
Thank you, Pawan. Now, can we go to Ajay, please? Are you ready, Ajay?
Yeah, let me, Pooja. Let me try that now.
Yes, Ajay. We are waiting for your presentation.
Can you ask the administrator to help him out, please?
Yes, sir. Just first open your presentation, then share your screen, sir.
So talk to Dr. Ajay. He's probably having a difficulty in sharing his screen.
Dr. Ajay, if you can send me through by mail, I can open from my end and you can keep talking.
That's great.
Oh, okay. All right.
That's great.
So why don't you guys, let me send it to Arun then. Okay.
So we'll take the last one.
We go ahead with this and we come back to Dr. Ajay's presentation after this.
That's perfect.
Yeah, may I invite Dr. Arvind for LUTS in postmenopausal women. Yeah, Dr. Arvind.
Can you hear me? Can you hear me, sir? I just start the video.
Yeah, Arvind, hi.
I'll just share my screen.
We got it.
Can you hear me, sir?
Yes,
Madam, yes, ma'am. I'll just go to the postmenopausal woman. I'll just present my case first. My case is a 65-year-old postmenopausal female. She was referred with occasional abdominal pain with a serum creatinine of 2.1. No baseline was actually available. She complained in difficulty in passing urine. She strained to void and had occasional sense of incomplete evacuation. She had frequency and nocturia, but she had no incontinence, no stress or urge incontinence during coughing. Her past medical history was just remarkable for type 2 diabetes mellitus and hypertension. Both were under reasonable control and are not very long-standing. The abdominal examination was normal. She had come with an ultrasound and an on-contrast CT. The ultrasound showed bilateral hydronephrosis. The urine analysis was normal. I'll just go to the next slide. The non-contrast CT was very interesting. It showed bilateral hydronephrosis with thinned out parenchyma. What was remarkable was it showed uterine prolapse, and the ureters appeared to be stretched down and pulled downwards. The bladder was also displaced downwards. Her pervaginal examination showed a complete grade 4 uterine prolapse. The urethral meatus was easily visualized and appeared narrow. The vaginal mucosa was also atrophic, and there was ulceration in the vaginal mucosa. So my question is, if Dr. Shailesh can say, what would be the management, next step in management in this particular case?
Okay.
Shailesh, are you hearing it, Shailesh?
There are two Shaileshes.
We can
please take over.
સંભળાતું નથી આ કનેક્ટેડ નથી ને એમ નામ
we can hear you.
Hello.
I can ask Dr. Ajit or Dr. Lalita, can they opine on what will be the further management?
Yeah, actually,
Yes, I can hear you.
is known to cause.
Go ahead, Lalita. You are the
So what we did was, initially the prolapse was reduced and was held in place with a pessary. She was advised to apply estrogen cream twice daily on the atrophic mucosa. The hydronephrosis reduced, and the creatinine also reduced to a nadir of 1.2 milligram %. And after 3 weeks, she underwent a cystoscopy, a vaginal hysterectomy with the pelvic floor repair. The urethral meatus was only 12 French. However, the narrowing was extremely short segment. The urethra beyond the meatus was essentially normal. After the cystoscopic dilatation, she has been placed on long-term estrogen cream application. She has been prescribed pelvic floor exercises, and she's planned for review after 6 months. My question to the panel would be this. One, we have two separate issues here. One is, of course, atrophic vaginitis, and second is the prolapse. And both of these can at different points cause outlet obstruction. If we don't consider this particular, what I want to say is, do all patients with atrophic vaginitis require treatment? Would anyone like to? Dr. Waze, would you feel that all patients, when we get them in the OPD with atrophic vaginitis, should you treat everybody?
No, sir. Atrophic vaginitis requires a local treatment of vaginal estrogen cream for a period of 3 to 6 weeks time. At the end of 6 weeks time, we can easily find out.
So would you give it to all patients who come to you, or would you prefer to give it to people who are symptomatic or have meatal narrowing or have recurrent urinary tract infection? Are you going to only give it to that segment or to everyone?
I would limit to that segment. See, for example, if the patient is not sexually active and she has a recurrent urinary tract infection, then I would give her a clear choice that, well, she has a uterus which is grade 4 stage of prolapse. And in addition to vaginal these things, even once your pessary treatment is perfectly controlled, what is her cardiac status, and I will at least offer a definitive treatment in a form of a hysterectomy through my gynecological colleague, and thereafter reconstruction.
Dr. Arvind, I would like to answer your question. We don't need to treat every woman with atrophic vaginitis. So as Dr. Ajit said, only when women with recurrent urinary tract infections, the use of local estrogen is known to reduce the risk of recurrence of UTI. That's one indication. The second thing is, as you said, meatal stenosis, once we dilate either by cystoscopy or by dilatation, again, there is a little bit of controversy about the use of local estrogen, whether will it reduce the risk of recurrence of stenosis. But we definitely, for the benefit of doubt, we give them local estrogens, but not more than a 2-month period.
Would anyone in the panel consider a longer period? Because we are talking of a hormonal deficiency, and would you consider a longer period, and does it have any side effects? local application.
I would keep this on twice per week indefinitely because of the urethral stenosis.
Yeah, that's what. Yeah, are there any other dissenting voices? I mean, somebody has a different opinion on this.
See, longer for 6 months can be given once we rule out, once we've done a mammograms at least once in the recent past, and if there's no family history or personal history of breast or uterine malignancies, we can give it for a 6-month period, but not every day. Use it twice a week. That is the, the treatment advised for long-term estrogen therapy.
Would the risk of a local estrogen therapy be equivalent to a systemic estrogen therapy? That's
No, it is not equivalent to systemic estrogen, but still even local estrogen has a risk because it's going to get absorbed to the system. It's not just staying locally and acting only locally. It gets absorbed into the blood circulation. So even local estrogen, long term, we have to keep a careful watch.
Would anyone consider a myotoplasty or urethroplasty in these short segment meatal narrowing?
The short segment, can you define what is a short segment?
It was just at the meatus. I mean, proximal was normal.
Probably it was probably a positional because of the uterine descent, which is grade 4. The treatment of choice in this woman would be once if she has a good cardiovascular status, if the anesthetist, she can easily and safely undergo a vaginal hysterectomy followed by vaginal reconstruction. That is probably the way to go for this woman.
Yeah,
That's already been done.
That's
been done.
So,
following that, you found urethral meatal stenosis. I don't think for such a short segment stricture in the distal urethra, we would do a urethroplasty.
So my second the second point here is we have uterine prolapse that can independently cause outlet obstruction. I will confine myself to outlet obstruction, though there was also ureteric obstruction here. Now, prolapse is believed to etiological factor for both urethral and stress incontinence. Who among the panel would consider a concomitant anti-incontinence procedure? And how would one go in algorithmically in such cases?
See, I'll give you two and fro views on this segment, whether to do concomitantly or whether to do a stage procedure. If you do concomitantly, the chances of obstruction because of the mid-urethral sling or a facial sling between 8 to 9%. Vis-a-vis, the chances of she getting incontinence after 3 months of evaluation is about 7 to 8% time. So you have to do pre-counseling before you undertake the procedure. What I would do is a stage procedure. If the good hysterectomy and good big flow reconstruction is done, you probably would just not need an anti-incontinence surgery in a later stage.
Yeah, we call this occult stress urinary incontinence. We don't advise preemptive anti-incontinence surgery, but we would counsel the patient that she may need a second procedure, and some of them have very mild stress incontinence. They may not even ask for a surgical correction. So we don't do it as a single procedure. Preemptive is not advocated in our scenario, my opinion.
Would you consider, Dr. Powell, would you consider reevaluation of the stress incontinence after placement of a pessary before the surgical intervention?
Yes.
Okay. My last question to the panel would be: is there a role of urodynamics here, particularly if you are considering reevaluation of stress incontinence?
I think it's definitely there. I mean, you're talking about a patient who has had a bad, she dilated upper tract, she had and she definitely had a bladder pathology. So after doing a successful surgery on the prolapse, if you think about it, incontinence and then advises surgery. So I think urodynamic after surgical correction of prolapse is absolutely mandatory.
Okay. Does anyone have any comments on this?
Actually, to diagnose occult stress urinary incontinence, we do a urodynamics after reducing the prolapse before the surgical correction of prolapse. So this actually gives us a better idea of how to counsel our patients, what to expect after prolapse repair. What are the chances of she developing stress incontinence? Definitely, there is a role of urodynamics if you have an access to that.
But does it? But if you look at the literature, the role is not very well defined, and it doesn't actually add to the final outcome.
If you're considering a surgery for stress incontinence in this woman after correction of prolapse, then urodynamics was by any standards, urodynamics would be necessary. And I think our Indian guidelines would definitely support that. Indian guidelines for incontinence support that very strongly.
Okay, I think we have come to the end of our time as well. Thank you so much.
Thank you very much, Arvind. Thank you very
Arvind, you.
Can I request
Arvind.
Ajay Singla,
Hello.
please?
Yes, sir.
Yeah, I'm here.
Okay, you got your problem sorted out, sir? Through
Well, actually, Arun has my presentation.
I'll
now.
present it. Arvind,
Okay,
can
he'll
you answer?
present. Arun is our boss here.
Are you ready?
No, I'm sorry. Yeah, no, I'm sorry that there was some technical issues.
That's perfectly all right. That's perfectly all right.
I don't know what the problem was, but
Arun can who is Arun?
Can you see, sir? Can you see the
yeah,
presentation?
no, I can see it.
Yes,
I can-
Dr. Ajay?
Yes.
You will keep guiding me when to go next. Then I'll be going with the shuffling of the slides. Okay.
Okay, sure.
Okay.
Well, thank you all. I want to really thank Arun and the USI for including me in this webinar. I was given the task of female bladder outlet obstruction following a mid-urethral sling. So I do have a case, but I'm not really going to ask anybody questions. I'm going to overview this topic also. So talking about female bladder outlet obstruction following mid-urethral sling. So how prevalent is it? So bladder outlet obstruction after any anti-incontinence surgery varies between 2.5 to 24%. And incidence beyond 28 days following a mid-urethral sling is actually less, 1 to 10%. And mid-urethral sling has lower rates of obstruction as compared to our traditional facial autologous pubovaginal sling. The transobturator tape has a lower rate of obstruction versus retropubic sling, means your TVT, with the overall rate of bladder outlet obstruction being 3%. This is actually the famous Thomas trial showed us. And even the LUTS, which is the urgency and urgent incontinence after a mid-urethral sling, could be up to 20%. Surgical intervention rates in actuality following a mid-urethral sling is actually pretty low, 1 to 2%. Can you go to next? So I'm not actually going to spend too much time on the presentation. The symptoms could be obstructive symptoms, it could be a storage symptoms. Patient may have a complete urinary retention. Next slide, Arun. So to evaluate a patient with the post-MUS outlet obstructive symptoms, you probably should take a detailed history, prior urological intervention, what surgery was done, any underlying neurological disease which was actually missed or we did not know before, any voiding dysfunction, continence status, duration, how far the surgery was done, how long ago was surgery was done, and the timing of the onset of symptoms. Pelvic examination should focus on your prolapse, presence of prolapse, hypermobility of the urethra, and you would be able to see or feel the constriction ring, which is a fibrotic scar from your tape. Then post-wide residual video urodynamics and cystoscopy. Next. So this is our index patient, typical patient of 59 years old, female. She has a history of both obstructive and storage symptoms following MUS. She had a transobturator tape placed 4 weeks ago. Her PVR is about 200 cc. She has a BMI of 26, and this is her pelvic exam is unremarkable. There's no pelvic organ prolapse on exam, but there is a constriction ring felt in the mid-urethra at the site of the scar, but there is no mesh erosion. Her urodynamic evaluation, this is your UDS, which shows typically that she has a high voiding pressure. It's actually even close between 40 and 50 centimeter of water. and actually has a low flow. So by urodynamic definition, she does have a bladder outlet obstruction. Arun, next slide. So she underwent a sling incision. You can see, within 4 weeks period, you should be able to feel you can see the sling, and then you can actually place your right angle clamp between the urethra and the mesh, and then you can incise the mesh in the midline. Next slide, Arun. So the urodynamics following the incision clearly shows that her obstruction has resolved. Her voiding pressures are now low. She has a pretty good flow on the voiding study. Next. So when we talk about the timing of the surgical intervention, when to intervene, so there are particular reasons for early sling mobilization. One is difficulty in performing a mobilization procedure with time because the tissue in growth into this mesh, and also a possibility of urethral injury because of the extreme scarring. Or delayed intervention may not improve the storage symptoms afterwards, and a long-standing obstruction may actually have some irreversible impact on her bladder structure and bladder function. There's also increasing risk of recurrent stress incontinence. Next slide. So for the timeline for intervention in a typical pubovaginal sling, what we do is usually you wait for 3 months and then you do the urodynamics if the patient still cannot void. For a mid-urethral slings, the intervention should be much earlier than that. If there is a complete urinary retention more than 48 hours, one should intervene. Or if there is significant voiding dysfunction within 2 weeks, and it should be customized to individual patient depending upon botheration. Next slide. So the main concern in all these procedures are risk of recurrent stress incontinence. So what is the prevalence of recurrent incontinence? Its incidence varies depending upon the series, depending on the literature. It goes up to even 60%. Sling excision versus sling incision. When you do a sling excision, it is 6-fold incidence of recurrent stress incontinence. Sling excision, the risk of recurrent stress incontinence varies between 14 to 19%. And when you go for a urethral lysis, the incidence is up to 25%. There's also a risk of de novo urge incontinence following a sling revision, even up to 43%. Next slide, Arun. So how do we manage these patients with female outlet obstruction following a mid-urethral sling? So you could have a non-surgical management, which is your behavioral techniques, biofeedback, some medical therapy, alpha blocker, antimuscarinic agent, beta agonists, clean intermittent catheterization, urethral dilations, which also have been reported more than 80% improvement if done early. The various surgical options are your sling loosening, just loosen the sling by placing a right angle clamp or a tonsil clamp and pull the sling downwards up to 1 to 2 centimeter. Sling incision, which could be done in the midline or could be done laterally. Sling excision could be a partial sling excision or a complete sling excision or removal. Urethral lysis, first you attempt on the transvaginal urethral lysis, and if it fails, then you have to do a redo urethral lysis. Then you should do a retropubic urethral lysis or even a suprameatal urethral lysis. So what are the success rate of all these surgical maneuvers, surgical management? They have a very high success rates. Sling loosening has up to 96%, sling incision is 90%, but it has to be done much early, within 4 weeks. Sling excision, if you do it after 3 months, still is pretty successful, even up to 90% reported. Urethral lysis also varies between 65 to 93%. When you go for a repeat urethral lysis, which could be a retropubic urethral lysis, again, it has a very high success rate of up to 90%. Next slide. So this is actually taken from a Victor Nitty's article on the algorithm for this female outlet obstruction following a mid-urethral sling. So in early intervention up to 2 weeks, sling loosening or sling incision, which can be done in the office under local anesthetic. And if there is no intervention required, you can just watch these patients. If your sling loosening or incision fails, you can still try a transvaginal sling incision again in the OR, making a lateral skin incision if midline incision has failed, or even a bilateral incision. If that fails, then you can go for the transvaginal urethral lysis first. And if that fails, then you should go for a retropubic or a circumferential urethral lysis. Now, when you are considering the erythrolysis versus a partial excision of these tapes, again, this is also a decision tree taken from Victor Nitty's article. Anti-incontinence sling placed, and if patient continues to have lasting obstruction, then you try the partial excision, and if it has failed prior partial excision, or you don't even know what type of sling material was used, or any other anti-incontinence procedure has been done, or in some exceptional cases at the discretion of the surgeon, you should actually go for erythrolysis. If there are no prior failed excision or there is synthetic sling, do the partial excision. So in conclusion, this is just based on this, give you your level of evidence. The symptoms of voiding dysfunction following mid-urethral sling can range from complete retention to various voiding alteration. There is no standard classification of types or degree of post-MUS voiding dysfunction. Clinical diagnosis is the norm. However, current practice is quite variable. The value of urodynamics in diagnosis confirmation or management planning has not been established. Most cases of post-mid-urethral sling voiding dysfunction are temporary. Treatment options and the long-term voiding dysfunction are limited, but should be taken to the patient's need and circumstances and level of surgical skills. Clean intermittent catheterization is a reasonable short-term option, but can be used for a long-term who do not accept the risk of recurrent stress incontinence. There is no evidence supporting the use of urethral dilation of voiding dysfunction post-mid-urethral slings. Next slide. Early mid-urethral sling mobilization or loosening is associated with a high success rate in resolving your post-MUS voiding dysfunction with a significant lower risk of recurrent stress urinary incontinence compared with incision or excision. When surgical revision of mid-urethral slings is undertaken, there is no clear evidence to favor either incision or excision with regards to relief of voiding dysfunction or the risk of recurrence of stress urinary incontinence. And lastly, the bladder storage symptoms may persist after the sling incision or excision, especially if intervention is done late after surgery. Thank you very much.
One question to you, Jay.
Yeah.
I think very good review of the whole problem. The point is that whenever such a situation occurs, we see that we wait for some time. We wait for 2 weeks. We wait for 4 weeks before the symptoms of obstruction resolve spontaneously. Now, in your case, it seems that you have performed urodynamic evaluation at about 3 weeks or so because your surgery was within 4 weeks of surgery. Now, the question here is, how long do you wait for spontaneous resolution of the symptoms of obstruction? And if so, then wouldn't that be too late to divide a sling if you have to do it anyway?
Well, it all depends on the symptoms and how much, if she's having a high residuals or not. So I think if she has a very significant symptom, then you probably should intervene early than late.
Ajay, can I ask?
That's what my opinion is, yes.
Can I ask a question? The chair?
Yeah, yeah.
Okay. Do you do a translabial ultrasound or a perineal ultrasound before you go in to excise the slings?
I personally don't. I know it is reported in the literature. A lot of people actually do it.
We do it regularly before we go in to excise the slings, just to make sure whether it's a properly placed sling, first of all. Not just it's a tight sling, whether it's a properly placed sling.
Or even in size, I would say.
But if she's obstructed, does that really change your management, Shailesh?
Well, then I won't excise. I will, as far as possible, excise, not just incise. I would, as far as possible, excise the sling, not just give an incision.
Yeah, can I add one point here, Dr. Ajay, and rest of the panel? See, fortunately, after mid-urethral slings, a very significant voiding dysfunction is rare, as we all know. And most of the times, as you said, we need to act early rather than late. If there is severe obstruction, total retention, I think the earliest, the best is to go in within a week, within the first week before the tissue ingrowth occurs, so that we can actually just release the sling instead of incising or excising. And for even for severe voiding dysfunction, I'm sure the sling incision would work. Actually, the sling excision is most often required for erosion and other type of complications rather than just for obstructive voiding. That's what I feel. Incision should be sufficient even to release a severe obstruction.
Yeah, that would be your first preference would be the sling incision. But if that fails,
Yeah.
that's what I was saying. If that fails, then you may have to go for a partial excision.
Yeah.
Only on the one side, one arm.
Yeah.
Do you agree, Charles?
Well, thank you. Can I now request Arun Chawla to take over, please?
Yeah. Thank you, Chairperson and expert, and thank you all the speakers for an excellent case presentations. Before I hand over to Dr. Rajiv TP, let me just make a brief comments on practical points which I could get from the speakers' presentations, and all the presentations were very good. An excellent presentation from all the speakers. Coming to the talk one, which was an evaluation of a female with BO, I think Dr. Amita Jain made a very strong point that systemic approach is very important, and internal pelvic examination by the urologist and the clinician should not be casual. Coming to Dr. Nikhil Khattar's presentation on urodynamic diagnosis of BO, he brought to our attention the different values of PDET Qmax in combination with the Qmax in the diagnosis of BO. But what he brought to our key point of the video. The video urodynamics plays an important role, especially in differentiating the functional causes as well as the neurological causes. Coming to the presentation by Dr. Charles Powell on dysfunctional voiding and Fowler syndrome, he brought to our attention the importance of correct history and stress on the important history taking. And he brought the value of PDET Qmax, which is more than Qmax, as an indicator of bladder outer obstruction. He brought the importance of MRI and ultrasound in picking up the and the hypertrophied uterus sphincter, not the bladder neck, but the uterus sphincter in the patients with Fowler's and dysfunction. And he brought to our notice the importance of EMG tracing, which looks like the helicopter tracing. Regarding Dr. Sanjay Sinha talks on bladder neck obstruction, he emphasized that it remains a blind spot still. It's easily missed, and you should always start in women with BO. But it does exist. It should not be missed in women presenting with the voiding LUTs. And he mentioned how he gives the vision. Can somebody just the background noise people a little muted? Yeah, thank you very much. So he brought the importance of giving a incremental incision, which is very precise. It doesn't go into the bladder; it stays at the bladder neck, and it doesn't exceed more than 1.5 centimeter. He goes step by step, millimeter by millimeter, into the bladder neck and relieves obstruction. Though the literature mentions the theoretical incidence of stress incontinence as well as the uterovaginal fistula in incision which are deep, and literature does mention about the incision at not only the single but a double incision at 5/7 and 2/10. Coming to the stricture, the talks by Dr. Sarika and Dr. Pankaj were excellent, but it is important whether it's a dorsal or the ventral approach, the results are equally good. Though the ventral approach disturbs the uteropelvic ligament support, but even if the stricture by ventral approach, which are very long up to proximal urethra, the stress incontinence is very rare. Nikhil has brought in his article published the importance of improvement in sexual function score by the dorsal approach. I think the similar results can be theoretically achievable by the intrauteral graft placement as Pankaj has described his technique. Regarding Dr. Gopal Badlani's talk on diverticulometer was very nice. What he emphasizes, if you keep in mind, you diagnose more. That was the key point. And he mentions that how important it is. You have vaginal wall on the outside and the urethral layer on the inside, And in between, you have to decide about, depending upon your technique, whether you bring marshes or you bring the pubovaginal sling or the tissue sling, depending upon the incontinence and depending upon the shared decision between you and the patient. And last of all, Dr. Maheshwari's talk on POP was excellent. I think you need always a gynecological support and your colleague to be there when you are doing this type of surgeries. It was excellent. Case scenarios were excellent. I thank all the speakers, all the experts, and the viewers. Thanks very much. And over to you, Dr. Rajiv TP, for your concluding remarks.
Thank you, Arun. It was an interesting webinar on a topic which is not that uncommon, but very less reported. And this program was well compiled, and it covered most of the aspects related to the bladder outlet obstruction. As all the speakers done an excellent job, and it was really interesting because this touched upon the anatomical aspects, the evaluation part, as well as the management. The case scenarios discussed were very interesting, and the experts, it was very interesting to hear the experts opining on how to deal with the various case scenarios. I, on behalf of the USI and Indian School of Urology, first of all, would like to extend heartfelt thanks to the international faculties for sparing their valuable time and to be a part of this USI ISU webinar and helping to make it a great event. Again, thanks to all our national faculties and the experts for the wonderful presentations and the discussions it has elicited, and the experts have expressed their expert opinions, which is really worth mentioning. And I again thank the Sun Pharma supportive team for all the logistic efforts, and also the central office, Navaneet and Kiran, for all the supports they are rendering, and they are really working behind the door, and they have been a real support to me for carrying forward these academic events. Thank you all once again, and again wish you all a very happy and prosperous Diwali. We had a wonderful webinar on this Diwali day, and again all of you had spared 3.5 hours being away from the family on this festive day. Thank you once again.
Thank you. Thank you, one and all. Thank you.
Thank you. Thank you, everyone.
Stay safe, stay well, sir. Thank you. Thank you.
Yep. Stay safe.
Thank you, Raj.